Hi, Dr. Dinesh.
Hi, Akshay. How are you?
Good.
Hello. Hi, Chandrika.
Hi, good evening, sir.
Hi, Dr. Bala.
Hi, how are you?
I'm fine, sir. How are you? How is Chennai?
Chennai is fine. The weather for a change is good.
We will start at 6:20, 2 minutes from now.
Hi, Dinesh.
Hi, sir. Good evening, sir. How are you, sir? Long
I'm
time.
very fine. Yes.
Long
COVID. Thanks to COVID.
time. Meeting virtually.
Yeah, meeting virtually. Anyway, this is a great topic you guys have chosen. So let's hope we'll have some learnings out of it.
Yes, sir. Wait, both Dr. Chandrika and Dr. Akshay have done a great job. And I think,
Certainly.
And, putting it all together.
And they've been able to get some very good speakers. One already there, Dr. Raman, ready.
Yes, sir. Excellent. National and international speakers.
Hi, Dinesh. Hello, Dr. Sir.
Hi, Abor. How are you?
Hi, Abor. How are you?
Oh, I'm good. Nice to see you all. Hello, sir. Dr. Yes,
Good
sir.
evening, Ibar. Good evening, Ibar.
Good evening, sir. Good evening.
Hi, Bor. Yeah. So we'll start now.
Hi, Akshay Satish.
Hi, Dr. Satish.
We'll start, Chandrika.
Yes. So good evening, everyone. On behalf of Rainbow Children's Hospital and the organizing committee, I welcome each one of you to this first conference on cytokine storm in children. We are pleased to let you all know that we've had close to 2,000 registrations for this event, which will be held over 3 days. And before I move forward, so as you all know, we lost two very big stalwarts in the field of pediatrics, Dr. Hector Wong, who's a pediatric intensivist at Cincinnati Children's Hospital, and Dr. Rolando Simas, who's the head of pediatric rheumatology in Florence, Italy. So we dedicate this conference to both of them who have done a lot for research in the world of sepsis and cytokine storm, and we'll always remember them for their great work. So before I move forward, just a few housekeeping rules. Apart from the speakers, I request all of you to kindly keep yourselves on mute. Please post your questions in the chat box, and the chairpersons or the moderator will take it up at the end of every session and every talk. Alternatively, you can also post your questions on YouTube if you're watching it live from there, or also on Twitter and the Telegram live discussion group. We will take all the questions from there and post it in the chat box here. And please actively participate during the conference so that you gain maximum benefit from this event. We have a fantastic line of speakers, and we have been very fortunate to have all the stalwarts join us from across the world today. So I welcome each one of you, and I now request Dr. Akshay to provide a brief overview of the program today.
So good evening, everyone. I'm Dr. Akshay Shetty. I'm a pediatric intensivist at Rainbow Children's Hospital. On behalf of the organizing committee and Rainbow Children's Hospital, Bangalore, I extend a warm welcome to all the delegates from India and across the world. Now, reason for creating this event essentially born out of the need of saving really sick ones in ICU, especially those ones with the multi-organ dysfunction. We all know that despite the available protocols, there are certain set of patients with multi-organ dysfunction who die despite of the best efforts. If anything good can come out of this COVID pandemic, it's probably the understanding of the role of immunomodulation. The simple things like Dexamethasone has saved countless number of lives during this COVID pandemic. And for us, all of those who work in Indian context, subcontinent, the multi-organ dysfunction predominantly happens in the context of tropical diseases like dengue. One of the aims of this meeting is to explore the role of immunomodulations in many of these tropical conditions like dengue and see if we can do better from what we're doing now. We've been incredibly lucky that we've been able to get global experts who have done innumerable amount of, who has done a phenomenal amount of work in the field of immunomodulation. Despite their busy schedule, they have agreed to join. We extend a deep gratitude for taking their time and attending this event. Now, this event is unique in the sense that it's purely multidisciplinary. We have both intensivists as well as rheumatologists discussing on one particular topic, that's cytokine storm. So we've designed program in such a way that we want to decrease Zoom fatigue. So we have extended it over 3 days, trying to cover most of the relevant aspects, practical aspects when it related to cytokine storm. We hope all the delegates who are attending to participate actively, like what Dr. Chandrika mentioned, post their questions in the chat box or on the YouTube or on Twitter. And we really hope to take them up at the end of each of those talks. At the end of every day, we have a case discussion. The idea behind case discussion is to bring out the practical nuances about managing immunomodulation in very sick children. And we don't want it to end as just a theoretical discussion. So with this, I welcome all of you for this meeting. And I really hope this meeting meets the expectation, meets your expectation over the next 3 days. It's my privilege to welcome Dr. Denis Chiller. He's a director of Paediatric Intensive Care Services of Rainbow Children's Hospital across the country. So I would request him to provide a welcome address and invite the chairpersons for the first session. I think you're on mute, Dr. Denis.
Thank you, Akshay. Good evening, everyone. And first, on behalf of Rainbow Children's Hospital, I take this opportunity to invite you all to a fantastic conference. And I take this opportunity to congratulate both Dr. Chandrika Bhatt and Dr. Akshay Shetty for designing such a nice program. And as I said, to avoid a Zoom fatigue, to sort of put it over next 3 days and actually get some meaningful discussion over the 3 days. As an intensivist, we all know that, and this is, COVID has made certain things more popular, and one of them is, of course, the cytokine release syndrome. Many of us did face during managing dengue fevers and other things, the challenges of differentiating between hyperferritinemia versus cytokine release syndrome. What is the right modalities of treatment? And many of times we got stuck with it. And fortunately now there's a good sort of understanding and multidisciplinary approach between a rheumatologist and pediatric intensivist. And that is something which this program has, that you can probably treat better some of these very sick children by collaborating with specialists who understand this better and probably choose the right medications for these children. Now, I think over the 3 days, the program has been sort of, very nicely designed, which actually facilitates discussion. And the program is as good as the speaker. And I think they, both Akshay and Chandrika have done a great job of getting great international experts and the national experts who could sort of, who are not only experts on these topics, but who could also initiate good discussions and who have great experience in managing such situations. So without wasting much time, I sort of welcome you all and hope it will be a great sort of scientific discussion. And I'm sure we'll have some great learning points at the end of this meeting, and we should be able to save some more lives with this. I take this opportunity to sort of introduce two of my very good friends. I think for all those from India, we don't need to sort of introduce very well-known figure, Dr. Balasubramanian himself, the chairperson for today. He's a medical director and head of Department of Pediatrics of Kanchi Kamakoti Child Trust Hospital. and is honorary pediatrician at Southern Railway Headquarters Hospital, Chennai. More than 100 index publications and nearly 600 CME sessions with 10 orations. Distinguished TNB teacher awardee from NBE. People love to attend his classes. He's got a Lifetime Achievement Awards from Tamil Nadu MGR Medical University. He has been a chairperson of the IIP Infectious Disease Chapter, and he's an advisor for ACVIP from 2020 to 21. And my good friend, Dr. G.V. Baswaraj, and he's the most popular person across the country, who is currently the Honorary Secretary General of the IIP 2020-21. Currently the Professor of Paediatrics and in charge of the PICU at the Indira Gandhi Institute of Child Health, Bangalore, and a course coordinator for fellowship in pediatric intensive care. He has been the founder secretary of the IIP Infectious Disease Chapter, Karnataka, and the chairperson of IIP Intensive Care Chapter in 2020, and been the convener of Scientific Committee of Pedicon 2017-18. He has the FIP Award in 2017 and also awarded the Dr. B.C. Rai Award by IMA Karnataka in 2020. So off to two eminent and distinguished teachers, Dr. Bala sir and Dr. Baswaraj, off to your sessions.
Can we start, Dr. Chandrika?
Yes, sir, you can start.
Sure, sir, please do.
Yeah. Thank you, Dr. Dinesh. But when Dr. Chandrika invited me to chair this session, I was terribly worried because I know very little about this CRS. In fact, I want to call this COVID reinvented syndrome. It's actually cytokine release syndrome has been reinvented by the rheumatologists, and then they have passed on to poor general pediatricians like me. But when Dr. Chandrika invited me to chair this session, I was terribly worried because what's happening? Yeah, am I audible now?
Yes, sir, you are.
Yeah. So I want to call this COVID reinvented syndrome, which has been passed off by the rheumatologists to the intensivists and then to poor general pediatricians like me. In fact, we have three interesting lectures during this session. The first one is by none other than my close friend, philosopher and guide, Professor A.V. Ramanan, who, of course, doesn't need introduction even to an international audience consisting of pediatricians and immunologists and rheumatologists. But then I have to follow the protocol and introduce him appropriately. He is the professor of pediatric rheumatology at the University of Bristol, UK. After his training in India, he left for UK and has climbed the ladder in pediatric rheumatology very fast. And he is well known for his research work in uveitis, cytokine release syndrome, macrophage activation syndrome, hemophagocytic lymphohistiocytosis, and now of late in COVID-19. And he has been involved in several research projects across the world related to rheumatological and infectious disease related problems in pediatrics. And it's my great pleasure to invite Professor Ramanan to start this conference with this session. Over to Professor Ramanan.
Thank you very much, Dr. Balsuram. I'm going to try and share my screen first, and then that's okay, isn't it? So you can see the screen fine?
Yes, we can. Ram.
Yeah, that's great. Thank you very much for the kind introduction. It's an amazing conference with an incredible list of speakers that has been put up, and it's an absolute pleasure to be starting off. But it's also an incredible challenge because Chandrika, who I thought was a good friend, has given me probably the most difficult topic. She says define cytokine release syndrome or cytokine storm syndrome and a host of things.
So I'm not going to answer many questions. I'm going to raise more questions than I'm going to answer, and I'm going to try and set the scene, as it were, which has already been touched on by a load of people. And you have an array of experts who will try and probably answer some of the questions I raise. I make no apologies for some provocative statements that I will make on an academic platform, but that's just to set the scene for greater discussion, as has been highlighted. So it's certainly something which has cropped up in the last couple of years, as been mentioned, because of COVID. But some of us who have been working in this area have always recognized that there is these conditions called by different people. The oncologist used to call it cytokine release syndrome in the context of CAR T-cell therapy, and I'll come back to it. And then in the context of COVID, the term cytokine storm syndrome took relevance, which hitherto was focused on small groups. And then you have the hematologist oncologist. It's an absolute pleasure for those who don't know that I'm going to be followed up by one of the world's leading proponents and researchers in the world of HLH, Professor Anakindra. And then the rheumatologist calling it macrophage activation syndrome. Some of this nomenclature has over the years, unfortunately, done more harm than good, because therapies are focused on different aspects. The hematologist or the oncologist would use things which the rheumatologist wouldn't. The rheumatologist would use things which the oncologist wouldn't. And then you had the CRS specific therapies, and then you had the COVID associated cytokine storm syndrome, whether it exists or not in all its profoundness in all of the patients, but it certainly shed light. As I always say, a condition's arrived when the New England Journal of Medicine does an editorial. So certainly, as someone alluded to, not just New England Journal of Medicine, but I think even the lay press, such as Wall Street Journal and New York Times, in the height of COVID, started talking about cytokine storm. Not always in the right context, but as they say in the world of PR, all publicity is good publicity for this condition if it does some good for the patient population who are critically ill. So as some colleagues have pointed out, you can see this in a wide variety of contexts. And that's why you have pediatricians, you have intensivists, you have infectious diseases specialists. So you have these, and I'm going to use the term cytokine storm syndromes because I think it's far better at encompassing everything rather than cytokine release syndromes. But I think the terms are interchangeable and the name is not what's crucial. But what you have is in the context of ARDS in the intensive care, and I think it's interesting, someone mentioned dexamethasone. 2 years ago, you would never get steroids past an intensivist, be it in an adult or a pediatric intensive care unit. And at last, we are coming to the recognition that even in infections, what kills you is not the bug itself, but the inflammatory cascade of cytokines that is released by the infective agent. And I'll touch on that more in this talk and a bit more in the later talk. And of course, we have malignancies, particularly anaplastic large cell lymphomas, which can present as in this multi-organ dysfunction cytokine storm syndrome. The infection sepsis associated, over which I think some of the cases are going to focus. The one we all recognize most is EBV HLH, which has been there for a couple of decades. But what's brought all of this attention to this condition, as has been mentioned by me and others, is COVID-19. And of course, the prototype autoinflammatory condition where we've long recognized a form of hemophagocytic syndrome, which is Still's disease or systemic onset juvenile idiopathic arthritis. But let's look at this picture from the NEJM, which I've taken the liberty of showing you, which describes the pleiotropic manifestations of cytokine storm syndromes. And you can have neurological manifestations presenting as confusion, hallucinations, delirium, a host of systemic manifestations, hepatosplenomegaly, which we all recognize, manifesting either as cytopenia and coagulopathy, which is the prototype, particularly in the DIC context or disseminated intravascular coagulation. Terms such as multi-organ dysfunction syndrome, systemic inflammatory response syndrome, disseminated intravascular coagulation used to be thrown about in ICUs, but they are not really syndromes which are descriptive of the pathology rather than actually being diagnostic terms. Occasionally, they get confused as diagnostic terms. In UK, you wouldn't get a bed unless you have multi-organ dysfunction in an intensive care. So this is just showing the absolute pleiotropic manifestations of cytokine release. And this is just another cartoon further focusing. And if you look in the lungs, at least in COVID, we've speculated that there is probably a picture which is organ limited. And certainly people have recognized CNS Hlh, which is very difficult diagnosis to make. And I think COVID is an example of organ restricted cytokine release. And then you will have kidney and liver. And certainly there are HLH presentations which are focused exclusively on the kidney. The vasculature and the lymphatic system is what we all recognize. And there are a host of other manifestations to do with rheumatic diseases, which we can touch on and is going to be covered. Well, what's interesting in the pathophysiological features, which again is from this is review, you can see that they talk about these iatrogenic causes, and we'll come back to this, which is the chimeric antigen receptor T cell therapy, which has really revolutionized certain forms of malignancy, particularly leukemias. And then you have the bacterial infection, EBV is a prototype, and then either perforin defects or perforinopathies, or the secondary HLHs, which may be autoinflammatory and then oncology driven. And what you have is an activation of T cells. I make no apologies for talking about immunology, which I'm going to do for the next 10 slides, because you cannot have a conference on cytokine storm and not talk about immunology, both innate and adaptive, and the cytokines. And what you really have is a hyperactivation of the immune system. And this can either be driven by the innate immune system. There is no extraneous trigger, and that is characteristic of the autoinflammatory conditions as well as some of the perforinopathies, or it can be through the adaptive immune system. And we believe that it might even be a complex interplay between these two. If you take certain infections such as EBV, which is fairly ubiquitous, why is it that only some patients with EBV go on to develop HLH and not others? But what you have really, as has been mentioned, is this ability to intervene in the cytokine storm. So we now have molecules which inhibit interferon gamma, which is now an approved therapy for primary HLH. We have Anakindra, which you will hear again and again, an IL-1 blocker. We have IL-6 blockade, which has now become standard of care in the management of COVID. And you have steroids, which are more a blunderbuss approach at suppressing the cytokine cascade. And there are only 3 drugs in COVID-19, which has been approved by WHO or advocated by WHO, and that is steroids, tocilizumab, and baricitinib. So really, the emphasis on understanding the cytokine storm in the context of these patients is because we now have several targets which we can individually target with these molecules. So let's look at these. The CAR T cell therapy as an introduction is in oncology, mainly in leukemia, which is infusion of the patient's own chimeric antigen receptor T cells to target the tumor cells. And when you have a cytokine storm from this, the standard of care happens to be tocilizumab. And that's where the tocilizumab use in COVID came about. And then you have certain specific molecules which target CD19 and CD3 specific T cells. And again, the treatment for that cytokine release syndrome is using tocilizumab. For EBV HLH, which is very interesting, people always use rituximab, which is mainly driven by gamma interferon TNF. We have bacterial sepsis, which is quite heterogeneous, and there may be a host of drivers. And the management so far has resulted in just managing with supportive care and antibiotics. And of course, with steroids, we spoke about, with COVID, we've spoken about the role of steroids, IL-6 inhibitors, as well as more recent approval for JAK kinase inhibitors. But if you look at a different context, primary HLH, which we've been working for 20 years, and Dr. Henter is going to talk more about this, there are clearly identified pathways, the HLH-94 or the 2004 protocols, which he'll touch on, and now with emapalumab. But then you have secondary HLH, which is a mishmash of a whole host of conditions, which is managed depending on which ologist you see, either with Anakindra or sometimes with JAK inhibitors or with steroids or with nothing. And then you have autoinflammatory disorders, which can occasionally give rise to macrophage activation syndrome, and which again are variably managed. So there's heterogeneity in presentation, heterogeneity in management because of the heterogeneous nature of different ologists. But let's look at some of those factors which bind or separate these. So if you take familial HLH, Mostly you will see these in young children, although there are increasing recognition of older children or even young adults being recognized with familial HLH. You will have high levels of gamma interferon and high levels of ferritin and soluble CD163. If you take secondary HLH, which we believe are heterozygous mutations in some patients, so they are predisposed, but they may need an extraneous trigger, and that might be an infection in this genetically predisposed host. Can happen across the ages. Adult onset Still's disease patients can still get it. Adult onset lupus patients can get hemophagocytic syndrome. And the picture is not too dissimilar to that of familial HLH. And then you have the cytokine release syndrome related HLH or MAS, where we don't know if there are any genetic predispositions. We know that there are some work nicely shown in COVID-19, for example, published in Nature about your anti-interferon antibodies making certain people more susceptible to having severe disease. But the picture at the level of the cytokines is not dissimilar. But when you come to sepsis, certainly there isn't a huge amount of gamma interferon, so that's probably not a pathway that you'd want to block if you want to treat sepsis-associated hemophagocytic syndrome. But for the rest, the ferritin elevation is not as high, not in the tens of thousands or hundreds of thousands as it is in HLH. And this will be explored more by the other speakers. But let's look at CAR T cell therapy, which is where the term cytokine release syndrome comes. And modeling cytokine release syndrome after CAR T cell transfer in this nice paper in Nature Medicine a few years ago reveals macrophages to be really pivotal in this process. And no wonder rheumatologists have called it a macrophage activation syndrome. They were just describing what was happening, while the literature is much more clear now. And you can see this working model of macrophage activation, release of cytokines, recruiting monocytes, and then the circulating monocytes were working on the macrophages again. And you have the damage-associated molecular patterns and the pathogen-associated molecular patterns, which might be important in sepsis, and the damage-associated molecular patterns may be more important in those with defects of innate immune system, which then leads to this vascular leakage hypotension, which might be what many of us may see as practicing clinicians, either in the ICU or in our clinic. And again, to demonstrate that the world is changing, we can now have molecules which block GM-CSF. Certainly lemzilumab has been trialed in adults with COVID-19 with some degree of success. Tocilizumab is well recognized now by the lay public even. Anakindra, and we know IL-1 is very neurotoxic, so there is a role for Anakindra in all its glory, not just in HLH systemically, but also in CNS manifestations of HLH. Now, the oncologists who have really gone forward with CAR T cell therapy for certain refractory leukemias and probably even multiple myelomas have a proposed mechanism as well as a pattern of grading CRS. So they say after the CAR T cell therapy, you have fever and mild symptoms, which is grade 1, which is very intuitive, or when you start having hypotension with organ toxicity, or when you're having hypoxia with significantly elevated liver transaminases and organ toxicity, or when you're really acutely, severely ill with multiple organ toxicities, raised transaminases, and needing mechanical ventilation. I show these as really a prototype for demonstrating the complexity and the grading that people use. Dennis McGonigal, my friend and colleague who's going to speak, I think, tomorrow, and I looked at the immune cartography in this Nature reviews, looking at MAS in the COVID-19 era because of the increased attention. And really what we are seeking to show is this same thing that I've illustrated. You can have classical MAS, which you'll hear a lot from Dr. Henter later on with gamma interferon and other cytokines, which is how we understand young 1-year-olds presenting with pancytopenia, coagulopathy with primary HLH, probably a perforin defect. But you can also have a cytokine storm leading to a capillary leak syndrome, probably something more the intensivists tend to see with infections, or the same with sepsis and multi-organ dysfunction syndrome, or a viral infection, be that EBV, or I'll make a case later on for dengue, which can present in a tiny minority with a DIC and a hemorrhagic picture. And a lot depends on the organ involvement and the role of the erythrocyte. So you can see the effects on the marrow with anemia and pancytopenia, or on the liver with elevated triglycerides, with the abnormal liver function test, which is very characteristic, and the coagulopathy, which Often some of these patients who die from sepsis get put down as sepsis, query cause DIC in the death certificate, when really it should be a hemophagocytic syndrome. And it does matter because you can make a difference with immunomodulatory therapy. And in the spleen, the splenomegaly will certainly account for the pancytopenia. And all of this is really explained by this macrophages releasing cytokines, which are then driving this disease process either through the marrow or through the liver or through the spleen. And what you see is a description of a condition which can happen both in the immunodeficiency context. So you have people with either perforin defects, which is primary HLH, or syntaxin mutations, or UNC13D mutations. So classical immunodeficiency, but you also have gain of function mutations, which is probably both converging to give the cytokine release syndrome. So the context is important, even though the final pathway is shared by a host of agents. So you can come in from either a gain of function mutation resulting in hyperactivation of the immune system, or you can have an immunodeficiency resulting in defective apoptosis, as in perforin mutations, resulting in persistent antigenic stimulation of the macrophages, resulting in the final common pathway of release of multiple cytokines, primarily driven by interferon gamma, IL-1, and IL-6. And I think recognizing this pluripotency of approaches for hemophagocytic syndrome or cytokine release syndrome or cytokine storm syndrome is important in getting us all ologists thinking of this in the same function. So we put this picture of thinking of this across the innate immune system boundaries. And these are artificial definitions because we know that there is a lot of crosstalk between the innate and adaptive immune system. But we put this cartoon to show that you can have loss of function with perforinopathy. We call it perforinopathy with primary HLH. You'll hear lots about it later. Or gain of function mutations, which we think might be more in certain forms of very rare MAS, such as NLRC4, which I think you'll hear from Scott Canna. Lupus-associated macrophage activation syndrome, which in the Indian context never gets recognized. A lupus patient presents with pancytopenia and gets put down as either sepsis or lupus flare, and sometimes they die without getting the appropriate immunomodulation that they should. And then you have the EBV-related lymphoma on one end again of the loss of function mutations. And the therapeutic implications, because ultimately this is not about navel gazing and talking about different terms for different conditions and publishing papers, but it's about saving lives in intensive care setting for children who come in acutely ill with multi-organ dysfunction, and for that matter, adult, even though I'm a pediatrician, I can only speak about children. And I think talking about where you target, we can now target IL-18 with a novel molecule. We can target IL-1, IL-6, GM-CSF. There are 2 molecules targeting GM-CSF, gamma interferon. And we may be able to make a significant difference in the survival and in the morbidity of children presenting with these conditions. And again, this is yet another extrapolation of what we show, that what happens at the intestinal epithelium level with the macrophages being activated, or in a lymphoma, or in a myeloid cell malignancy, or through the T cell receptors. And we make the SARS as an example, but that's more organ-specific pulmonary hemophagocytosis, or a pulmonary-specific cytokine storm, for want of a better word. And this is what I used to say 10 years ago as a more simple version. You have primary hemophagocytic syndrome, you have acquired hemophagocytic syndrome, which is virus-associated or infection-associated, you have rheumatic diseases, you have malignancies, and then you have immunodeficiency like Chidiac-Higashi or Griscelli. And I don't think it's changed much. There are a few more strands which we now add to this layer. So what is the diagnostic criteria? This is work of Henter and colleagues, which he'll touch on. And I think this is still extremely relevant. Fever, splenomegaly, 2-cell line cytopenia. Perhaps the level of ferritin is a bit too low. Soluble CD25 and NK cell activity are never really something you can get in the real world, certainly not in my experience, and would be much harder in several low and middle income countries. Marrow hemophagocytosis, when it's present, is good, but its absent doesn't exclude the diagnosis. And the organs where you get the greatest success are usually spleen and lymph node, which nobody's willing to biopsy. So let me show you why this is relevant. This is work done by Ethan Sen and colleagues, and I'm going to show the typical scenario is a 3-year-old boy presenting to a UK hospital, 2-week history of sore throat, fever, 1 week of reduced appetite, getting admitted with what's thought to be sepsis, now starting to have cytopenia, raised transaminases, coagulopathy with a ferritin which is almost touching 10,000. And this is the criteria. Now, increasingly, there is evidence to show that a ferritin of more than 10,000 on its own, which is universally available, is highly specific for HLH. What people have done is now look at how many of these cases are being missed in a multi-center audit in UK. So they looked at 8 tertiary UK teaching children's hospitals over a 3-year period and searched all the biochemistry databases for children with ferritins of more than 10,000. So we said if you have 5 or more of the 8 criteria, but if you have 4 or more, so if you have 4 or more of the 5, then that is enough, because it's very difficult in the real world to get marrow hemophagocytosis or NK cell function or soluble IL-2 receptor. So we said we'll modify it for this purposes of saying if you're 4 of the 5 that most people can get, then you have HLH. What did we find in that 3-year period across 8 hospitals? This is unpublished data, but presented at the Royal College of Paediatrics meeting. We found 94 cases, of whom about half of them really needed ICU admission, either pediatric or neonatal. About 1 in 10 was systemic JIA, well recognized, that's fine. There was no major ethnicity that was different from that of the population. And what you see is infections being a big chunk, oncology having a chunk, rheumatological indications and immunological indications. Interestingly, we found this both nationally as well as locally, that post open heart surgery, cardiac surgery for children with congenital heart disease, you do have high levels of ferritin and some level of cytopenia. Something to bear in mind that may not always be hemophagocytic syndrome, although we're starting to do work in piglet models of looking at giving tocilizumab for the hypotension that we see post bypass and post cardiac surgery to see if that will help. So maybe there are some implications for the cytokines that are released post cardiac surgery in neonatal cardiac surgical patients. So we found there were loads of patients who met the criteria but were not diagnosed, and I'm rushing through this in the interest of time, but really what we're saying is about 20% of the patients met 5 of the 8 HLH criteria, were all diagnosed as HLH, but another 30% plus met 4 of the 5, and 3 of the criteria is really not accessible to most immediately, and only half of these patients were diagnosed as HLH, and in a third of these, we couldn't even see evidence that HLH was being considered or hemophagocytic syndrome was being considered. So in a whole cohort of 94 patients, about 30% the diagnosis was considered, was made by the treating team. In a fifth, the diagnosis was considered. But in half of the patients, which is a startling number with a high morbidity and mortality, the diagnosis was not even considered. And there are different teams involved, which is why you see this conference having so much interest. Why is it important? Because a third of these patients die. These are a third of these children with high levels of ferritin, meeting 4 of 5 HLH criteria, die. And the mortality in patients diagnosed by treating teams as HLH was lower than the overall mortality. Probably a small indication that if you consider the diagnosis, perhaps you might adopt immunomodulatory therapies, which you wouldn't have otherwise done. So really, not considering hemophagocytic syndrome in children with ferritins of more than 10,000 can be quite costly for the child and the family. And I know Joe Carcillo, who's really a famous intensivist and has done extraordinary amounts of work on this, just published this less than 2 years ago, when and how is hyperferritinemic sepsis, and different from sepsis without hyperferritinemia, and I'd urge you to read this, but he talks about the role of ferritin promoting pro-inflammatory cytokine cascade, particularly with IL-1 and IL-18. So we published this a long time ago. We said, what does this leave the general pediatrician, as Dr. Balasubramaniam asked? Okay, if you have a child with fever, cytopenia, coagulopathy, then check serum ferritin. This is in a low and middle income country context. If it's more than 10,000, you're almost always dealing with a hemophagocytic syndrome, then you can take appropriate advice. If it's between 500 to 10,000, then you can look at doing some of the more sophisticated specialist markers. And if it's less than 500, it's not impossible, but it's less likely. At least you're not sitting on a child with hemophagocytic syndrome. And why? Because we're going to come back to this. This was the trial in the 90s of Anakindra, which Randy, who's in this call, understands well. Anakindra was trialed in adults with sepsis. It didn't show any efficacy. But when Beta Shakuri and colleagues did a subgroup analysis, they found that when you identify the sepsis patients, and that's what they did, they divided the sepsis patients into those with hepatobiliary dysfunction plus DIC versus those who had one of these or none. And they found that 763 adults were randomized to this Anakindra study. And about 43 of them had hepatobiliary dysfunction and DIC, a surrogate marker of hemophagocytic syndrome. So across the spectrum, the 28-day survival was same if you didn't have hepatobiliary dysfunction and DIC. But in those with hepatobiliary dysfunction and DIC, which is essentially a form of cytokine storm syndrome, if you got Anakindra, you had much greater odds at surviving. So demonstrating that even in a sepsis cohort, Anakindra in a carefully chosen selected few patients will improve survival. I want to finish by trying to demonstrate to you, it doesn't matter what you call it, it doesn't matter whether it's cytokine release syndrome, cytokine storm syndrome, multi-organ dysfunction syndrome, systemic inflammatory response syndrome. Consider them as part of the same spectrum, using terms which are not really diagnostic, but really not helpful. So SIRS and MODS, in my opinion, should be avoided in the intensive care context. And I think immunomodulation for patients in the spectrum should be considered when you have the right biomarkers, such as ferritin at very high levels. And the first criticism that's leveled at a cheap and cheerful biomarker like ferritin is, how do you know that ferritin doesn't go up as an acute phase reactant in any condition? And what I'm trying to demonstrate is, these are two studies showing that in patients, adult patients with trauma, both with and without ARDS, ferritin doesn't cross 1,000. In pneumococcal sepsis, both in those under 75 and more than 75 years of age, ferritin doesn't cross 1,000. So when you see ferritin in several thousands, it's unlikely to be just as an acute phase reactant, but it's showcasing a form of cytokine storm. And that's what several years ago Alan published, and others have now documented, that a ferritin of more than 10,000 is highly specific for hemophagocytic syndrome. So I'm going to stop, and I hope I haven't run over time, with what we published in PIDJ a few years ago with my colleagues to demonstrate to you a sort of algorithm for those who are general pediatricians or infectious diseases or intensivists on when to suspect hemophagocytic syndrome. I use that term hemophagocytic syndrome, call it CRS or call it CSS or whatever else you like. But really, what we want you to do is consider this possibility where immunomodulation may potentially have a role. And I'll leave with this slide and stop there and take any questions. Thank you very much.
Thank you, Professor Ramanan. It was, as usual, very informative, crisp, and crystal clear. Dr. Basraj, you can take questions from the audience. Dr. Chandrika would direct you to the questions.
Yeah, thank you. Thank you very much, Professor Ramanan, for an excellent talk. Yeah, Chandrika, you want to say a few words?
There are questions in the Q&A box and the chat box as well, if you can take that, please.
Yeah. So one of the question is, in a resource-limited setting, what can be the best surrogate marker aside the ferritin to assess the level of cytokine, Professor Ramanan?
Wow, I don't think there's better ones than ferritin. It's not a single marker that's going to make the diagnosis. But if you have a patient with presumed sepsis, with cytopenia, and you've got coagulopathy, if you have a ferritin, as we pointed out in that diagram, of more than 10,000, you're highly likely dealing with a form of hemophagocytic syndrome. The other markers are really hard to get, whether you're, it's not just whether you're in a low and middle income country or even where I'm working, you never get it in time. If you're working like Dr. Henter in Karolinska, then I think you have access to some amazing facilities, and he's been very helpful to me. But really, I think the ferritin in the context of the other markers is really important. And someone's talking about dropping ESR with the rising ferritin. So it's an important question. ESR drop is actually, ESR is a surrogate marker of serum fibrinogen. And so the reason you see the ESR drop in the face of inflammation is because you have hypofibrinogenemia. So yes, a drop in ESR is good, but I wouldn't hang my hat because you may not always get that drop in ESR, and ESR can be affected by a multitude of factors. But really, this biomarker I'd put the greatest emphasis on would be ferritin in the context of cytopenia and coagulopathy.
Yeah, one more question by Dr. Silky Jai. Is the fibrinogen a differentiating factor for HLH versus sepsis? What's the, where do we stand?
Well, I don't think there's enough data. So I'll show you later in the dengue talk that it tends to follow hyperferritinemic patients who we suspect have a hemophagocytic syndrome will have hypofibrogenemia, but it's a relative hypofibrogenemia. And that's one of the problems with the criteria, because a patient, for example, and the best example is a rheumatological example, a patient with Still's disease will start with a ESR of about 150, will have a fibrinogen of 8 or 9, and then as they go into macrophage activation syndrome, the fibrinogen will drop. But that drop will not be as marked as a primary hemophagocytic syndrome patient who will present with a fibrinogen, which is absolutely in the boots. So I am loath to give absolute values for other markers because a relative drop in the counts, a relative drop in the fibrinogen should be much more profound indicators. Whereas ferritin is an absolute one. Of course, the 500 in the criteria is far too low. But a ferritin of several thousand, I don't think even 10,000 is needed. 5,000 is good enough to in our own series, which is unpublished in Bristol, at least, we found that 5,000 under receiver operating characteristic curves was as sensitive and specific as 10,000.
Yeah, one of the questions from Dr. Devang Pandya. What is the dose of IV methylprednisolone is recommended as per your experience in the CRS? This is one of the common questions in the presently which is going to be raised.
Yeah, this is an often asked question. There are two mechanisms of action for steroids, as people have heard me say before. IV steroids work mainly non-genomic. Oral 1 to 2 milligrams works in a genomic mechanism. What dose of IV steroid is the right one, whether it's 10, 20, or 30? I don't think there is solid evidence. We use 30 per kilo to a maximum of 1 gram. But I don't think I can say that 10 or 20 is inferior, but I tend to use 30 milligrams per kilogram to a max of 1 gram.
Yeah, one of the questions by Dr. Ravi Ambe is from Indore, he is from Gwalior. So what's the role of IV immunoglobulin in CRS?
We don't know is a true answer, but certainly these will come up in some of the cases. The best evidence, which is really only case report evidence, is people have historically used immunoglobulin because that's what they can access, and there's always great comfort in giving immunoglobulin because you think it's not going to harm the sepsis patient, whereas there is a fear in giving steroids, and there is still a reluctance to give Anakindra in spite of me showing data that it was trialed in sepsis. Whereas with immunoglobulin, everyone's more comfortable because even if it doesn't cause any benefit, it might not cause any harm. In terms of its actual efficacy, in adult onset Still's disease patient, a group in Switzerland have demonstrated just with IV immunoglobulin 2 grams per kilogram, I think they gave a max of 70 grams, they were able to show resolution of macrophage activation syndrome associated with Still's disease. Everywhere else, IVIG was part of several other therapies that it's very hard to delineate what the impact of IVIG was in the management of HLH as opposed to several things being given at the same time.
One of the questions from Dr. Revan, in a dengue shock stage where we see a ferritin of more than 10,000 with hepatitis and DIC picture, majority will come out with a supportive care. Does really we need to start a immunomodulation in this type of a situation? What will be your thought on that?
Well, I thought I'll save it for the dengue talk. I think what you need to do is a trial. I don't think you need to take my word, and maybe I'll save the dengue talk for the dengue, the questions on dengue later on, so that if that's okay.
Yeah, we will take it in the next.
Yeah, I think there are quite a lot of questions, and chat box is exploding with questions, and I think most of those questions might be answered during the course of the conference. There are a lot of questions regarding ferritin, its value, its role in dengue, about what we do with multi-organ failure. I think a lot of those questions, I think over the next 3 days, there are multiple talks on similar topics. I guess many of them will be answered over the time. So,
yeah. So, can you
Dr. Henter might address some of these questions. He's got a lot of experience, so he will tell you some of these in his next talk. And if not, feel free to pepper him with questions as well.
Dr. Chandika, can you move on to the next talk?
Yes, sir. Please, you can introduce the next speaker. Thank you.
Yeah. So it is my pleasure to invite Professor John Enter. So he'll be talking about what we learn, lesson learned in a primary HLH and implementing them in a secondary HLH. It is a very interesting CV of Professor John. Professor John is working in a Karolinska Institute in Sweden. Is a senior consultant pediatric hematology and oncology, and is from the Sweden. He is graduated in the way back in 1980s. He is a post-graduation in 1987, and later he is defended a thesis in 1990 on a thesis at the Karolinska Institute of focusing on to the HLH. He is a specialized in pediatric hematology and oncology, and he is a principal investigator of an international HLH guideline in 1994 and HLH guidelines in 2004 studies. And he studied the underlying biological and genetic defect in HLH. Another main interest is in a secondary form of HLH also, not only the primary and secondary also. He is also interested in many field of medicine, including Langerhans cell histiocytosis, end of life care, and he has made numerous publications. He is co-authored more than 240 publications. He was the president of Histiocyte Society in the 2004 to 2007 and founding president of International Collaboration of a Rare Disease and Orphan Drugs. And during the 2012 to 2017, he was a director of research and education of Karolinska University Hospital in Sweden. He describes himself as a curious and enthusiastic explorer of the world and everything in it. So it is a great CV, Professor Enter. So it is now stage is open for you. What the lesson we learned in the primary HLH and implementing them in the secondary HLH. Over to Professor Enter.
Hello, ladies and gentlemen all over the globe. I would like to thank the organizers for the invitation. And then I will, my task today is to tell you about lessons learned in primary genetic HLH and their implementation in secondary HLH. With regard to disclosures, I have some very limited consulting for Sobi. So first, like an abstract, a brief summary of HLH. HLH stands for hemophagocytic lymphohistiocytosis, which represents uncontrolled hyperinflammation. And we've actually considered to change the name HLH to hyperinflammatory lymphohistiocytosis, still being HLH. It comes in two major forms to make things easier. One is then primary HLH, caused by inherited immune defects, as Ram mentioned.
Dr. Hender, your slides are not moving, sorry. If you could
okay.
Slideshows, thank you.
Is it moving or not? Not moving.
Not moving yet.
Then I have to stop share, probably, and then share again. This is what I've learned to do, this situation. So now we're there. You see the slide?
It's still not on slideshow mode.
It's not still on. I'm sorry for this, but I push the slide mode button, but you don't see it in slide mode?
Not yet.
I don't really know how to do it.
You can probably make it full screen.
Yes, we could see.
Do you have more than one screen, Anakindra?
This is sorry.
If you probably just click on the update button, maybe that would work.
Yeah, the yellow strip in the top, might be if you press an update button, it might work.
So you don't see don't see the slides moving.
Do you see the actual presentation?
Ja, det gör han nog. De måste kunna höra oss. Ja.
Men vad händer när du har du det nu?
You still don't see the full the presentation mode.
No, we don't. Maybe if you can just click on the update option in the yellow strip.
I'm a little bit uncertain what you mean with the update.
So there's a yellow strip at the end of which there's a white rectangle.
Vänta, nej, du måste sätta. Nej, fast det är inte där. Men om du stänger den igen. Är du på presentationen?
Precis, we can leave the presentation.
Or if there are two screens open, it can sometimes.
Nej, nu ska vi se. There are two screens. Probably that's a problem. See here. So there are two screens here now.
Yes.
So we have to stop one of them.
Which one? Oh,
so
okay.
we can stop this one. So we stop this one then. Stop share. Det är kanske still.
Men det är inte stop share.
I think it just worked when you opened your screen now.
Pardon?
Did it work when you opened the screen now?
If you could just open your presentation now and share the screen, yes. Make it full screen.
Huh? Can you see the full screen now?
No, not yet.
No, then you go back to where you were before because this is the other presentation. So if you close this, go out of this one, and then go back to the share screen, and then take that one.
In that case, maybe if we could go to the next talk and then come back once we sort out the.
We can do so, yes.
All right, okay. So I think we'll ask Dr. Ramanan to give us the next talk and then we'll come back to your talk.
I'm happy to, Chandrika, if that's what you want me to do, to help Yaningay sort it out.
Sure, that's okay with us if Dr. Yaningay is all right.
Yes, please go ahead. Yes,
yeah,
thank
you. I'll give you a good 25 minutes, Yaningay.
Ram, you're so welcome. Yes.
What he would do is, unfortunately, I feel sorry for everyone who's got to listen to me for 50 minutes, but if that's okay with the two moderators as well. Is that okay, Dr. Balasubramaniam and Dr. Basavaraja, if I do the dengue talk so that we can save some time?
Chandrika, we can ask Dr. Ramanan to go ahead with the dengue talk and then go on to the session for Dr. Enter. Okay?
Sure, sir. Yes.
Okay. Well, apologies, ladies and gentlemen, that you're having to listen to me twice. If my children were to hear me, they'll say listening to me once is hard enough. But there you go, without a break. So you are missing a world-class speaker in Yaningay, but I'm hoping in 25 minutes you will get to hear him talk. So continuing where I left, I was asked to touch about hyperferritinemia and dengue. I have to make a couple of disclosures here. Now that I'm living and working in Bristol in UK, I don't see dengue. What little I see and hear is through my good friend, Dr. Balasubramaniam, and the work I've done is with him. There is a colleague in Vietnam, Dr. Sophie Yakub, who kindly shared some slides with me. I've acknowledged her contribution and some work we're doing in Vietnam. So some of the work is what we have done with Child's Trust Hospital, some with Priyanka Pal in Calcutta, and some with Sophie Yakub we're planning to do. But on a day-to-day basis, while I would love to see dengue, I don't see dengue where I'm working now. For those who don't know, and those who have joined from the comfortable cold climates of temperate Western Europe and North America, Dengue actually causes more damage and continues to cause more damage in India, Bangladesh, Pakistan, Sub-Saharan Africa than COVID in all its glory. But one of the dangers of our excessive attention to COVID is things like TB and dengue get comfortably forgotten. Even in 2019, 2021, more children have probably died of dengue than they have of any form of COVID. It's a mosquito-borne arbovirus disease, which can kill up to 20% of those with severe dengue. Has been a huge problem, and like lots of tropical diseases, unfortunately, it has suffered from lack of attention. If only 1% of the attention of COVID was shed on dengue, then the world would have been a much better place and more children would be living to tell the story. 40% of the world's at risk of dengue fever. Most of this is in the tropical settings, and vaccines really haven't been that helpful. This is a slight courtesy wherever I mention of Sophie Jacobs. So Sophie, with whom I worked for the last couple of years, has done amazing work in Ho Chi Minh City in the Hospital for Tropical Diseases. She's based at Oxford University, where they have a 500-bed tertiary referral unit. And I thought this is much better to contextualize it through her slide of the number of admissions they see in Vietnam in this one hospital, which is anywhere from 8 to 15,000, with about 300 to 500 with severe dengue, and absolutely no therapeutic options, which most of my Indian colleagues know, apart from supportive care. Severe dengue, which is the most feared complication, which can lead to dengue hemorrhagic shock or shock syndrome, is when you have these capillary leak leading to intravascular hypovolemia. All the intensivists would well recognize it. The dropping platelet count and the coagulopathy is always a worry when it's accompanied with significant organ impairment, be that liver, heart, or the brain. My first interest came about because of what I showed to you with ferritin, and really with Dr. Balasubramaniam and Dr. Ramachandran. We looked at ferritin in a tertiary children's hospital, which is the Kanchi Kamakodi Child's Trust Hospital. What we did was very similar. We said, in a resource-limited setting where we may not have access to soluble CD25, not have access to natural killer cell function, and all the other fancy tests, let's see what we can do with just using ferritin as a biomarker. And how is this relevant to dengue will become apparent in a couple of slides. So in that 1 year period, they diagnosed 33 children with HLH, of whom about half required PICU admission, mainly if they were with respiratory distress or those who were categorized as having severe sepsis, with only 7 needing ventilatory support. The mean age was 4 to 6 months. The third of these patients had CNS symptoms. All of them had hyperferritinemia because that was a priori the way we categorized hemophagocytic syndrome. Low hemoglobin was seen in the majority, as was low platelet in 2/3. Low fibrinogen and high LDH was seen in the majority. Marrow hemophagocytosis uptake in this cohort was much higher than any other cohort, maybe because they were ability to do serial marrows or better at targeting. But this is where the relevance to the dengue comes in. There were 5 of these children who had dengue-associated HLH when we started looking at ferritin, 3 with EBV and other bacterial infections. And really, apparently, compared to previous years, the survival was much better when there was some targeted immunomodulation, be they steroids or immunoglobulin, or even in the odd patient, cyclosporin and etoposide, which are really the mainstay of therapy in primary hemophagocytic syndrome, which you will hopefully hear from Dr. Henter. And then, along with my good friend and colleague Priyanka Pal, we did this work in one outbreak of dengue in Calcutta, or Kolkata as it's now known, where over that outbreak of the 358 dengue cases, using just full blood count and simple markers such as ferritin, we thought 8 of them could have possible hemophagocytic syndrome, in whom we gave steroids, which currently isn't a WHO mandate to do in dengue syndrome, based on some really weak studies which have kind of nailed the death on steroids in dengue. It's similar to the story of steroids in Kawasaki. Both of them are based on poor studies and tend to get a bad rap. But this is work by the NIH colleagues, while ours was in a low and middle income country setting, in a low resource setting. What they're showing here is in EBV patients with HLH, in Yersinia patients, in dengue virus associated HLH, familial hemophagocytic lymphohistiocytosis, and HLH in Still's patients, there is significant uptake of the genes which are overexpressed in those with HLH. So dengue seems to share homology, even if you just look at the color patterns. It looks a lot similar in dengue and familial hemophagocytic syndrome patients, suggesting that perhaps the dengue patients who are getting the dengue hemorrhagic shock syndrome with high ferritins may have an underlying genetic predisposition, but certainly there's no argument that they are having a form of hemophagocytic syndrome or a form of cytokine storm syndrome, depending on what you call. And this ferritin level in this study certainly correlates, which I'll come back in showing more data, with how viremic they are. So the more viremic they are, the higher the dengue levels. And I'll come back to showing this data again in more, even though you're not going to be hearing Yaninge for another 20 minutes, this is Yaninge's data from Malaysia. And what they looked at is experiences of 180 patients with severe dengue, all of whom are adults. And what I'm trying to show here is if you divide the patients of these 180, those who lived, which is 141, to those who didn't unfortunately make it, which is 39, you see, let's look at ferritin. Non-survivors, the mean was 72,000 compared to survivors, which is 20,000. LDH, 6,244 in the non-survivors compared to 843. Certainly organ damage, which most of you as intensivists and who see dengue recognize that the renal failure patients tend to do much worse. And really the mortality is in the first few weeks, because the survival after day 43 was almost 80% in this Malaysian cohort. The characteristics which they identified in multivariate logistic regression was really increasing age at hospitalization in this adult study, a SOFA score, which all of you in intensive care will well recognize as one of the scores you use, particularly in adult medicine, liver enzymes in the form of aspartate aminotransferase, and peak creatinine. So the SOFA score, the AST and the creatinine were clearly associated with an increased risk of death. The higher the SOFA score, the higher the AST, and the higher the creatinine, which led Sophie, me, and Pooja, who's going to speak later on, to talk about whether we target the hyperinflammation in infection, and can we take some of this incredible momentum with immunomodulatory therapies in COVID to end the really absolutely sparse therapeutic trials that have happened in dengue, but a condition which causes significant morbidity and mortality in the tropical settings. And I go back to this paper, which although it's now 7-8 years old, is really was done in the Caribbean island of Aruba, looking at hyperferritinemia in dengue virus associated patients, and then looking at its correlation with immune activation and coagulation disturbance. And this is me trying to make the case to you that hyperferritinemia in dengue is a form of hemophagocytic syndrome or form of cytokine storm syndrome, or what you like to call it. What they did was divide these patients into those with warning signs of severe dengue, those without warning signs of severe dengue, and then look at hyperferritinemia in these cohorts. And there were no differences in the serotypes, but certainly the hyperferritinemic patients are more likely to be viremic compared to the non-hyperferritinemic patients. There was no gender differences. Hospitalization rate was much higher in the hyperferritinemic dengue patients compared to the non-hyperferritinemic dengue patients. And again, they had three cohorts: those with warning signs of severe dengue, those without warning signs, those with warning signs of severe dengue. And OFI stands for other febrile illnesses, because one of the common criticisms is if you start looking at ferritin in any fever, will it go up? And what is again demonstrated is in those with warning signs, there is a higher risk of ferritin, but much higher risk of ferritin fold infection. Other febrile illnesses do not have hyperferritinemia. But as you go down, you look at outpatient and hospitalized patients, you can clearly see that the ferritin elevation in hospitalized patients is much higher compared to other febrile illnesses, as well as in other forms of dengue. Higher the viral load, higher the ferritin load, and higher the ferritin fold change as well in dengue. So the more viremic you are, the more ill you are, the higher the ferritin you will have. Now, someone's asked the question, what else can we use in a hyperferritinemic dengue patient? So here I'm going to show you a series of markers which correlate with hyperferritinemia in this cohort from Aruba, which these colleagues published. So they have ferritin, the plain white box is ferritin less than 500, which is, as you know, the HLH cutoff. Ferritin more than 500 is the gray box, and the black box is other febrile illnesses. So you can see in those with hyperferritinemia, even though the bar is set a bit low, this is the dengue hyperferritinemic, is associated with a lower platelet count compared with the non-hyperferritinemic dengue patient, which is almost in the normal range. Other febrile illness, if anything, you get a high platelet count as an acute phase reactant. Similarly, you have a relative hypofibrogenemia, although this is not as prominent as the other febrile illnesses, which is why my reluctance to use hypofibrogenemia exclusively as a key marker. The transaminases, interestingly, significant elevation of AST and ALT in patients with hyperferritinemic dengue compared with non-hyperferritinemic dengue and other febrile illnesses, both of whom do not have significant elevations of AST or ALT. Soluble IL-2 receptors, if you can access them, and IL-18 levels, because this was an academic study, certainly there is elevation of soluble IL-2 receptor levels, although the IL-10 elevation doesn't really discriminate between hyperferritinemic and non-hyperferritinemic. Again, the soluble IL-2 receptor levels, as you might recall, is a key part of the diagnostic criteria of hemophagocytic syndrome. So really high transaminases, low platelet count, and high levels of soluble IL-2 receptor are all demonstrating that these patients have a hemophagocytic syndrome. Some believe the von Willebrand factor to be a marker of vascular endothelial damage, as well as the ongoing coagulopathy, and the thrombin-antithrombin complex, which is to demonstrate the coagulopathy that happens. And all of these are elevated in the hyperferritinemic dengue patients, which is the gray bar. And the same is true for the levels of decrease in thrombin, which again is a marker of coagulopathy seen in the hyperferritinemic dengue patients. And the plasminogen antiplasmin complexes, again a marker of coagulopathy, significantly elevated in the hyperferritinemic patients, while not being elevated in other febrile illness or in the normoferritinemic dengue patients. And the same for plasminogen activator 1 and D-dimer, which are all really repeated markers of coagulopathy and demonstrating that there is a form of hemophagocytic syndrome in those in whom we use ferritin as a marker of hemophagocytic syndrome. And really, all of that is fine. You may say, what is the relevance to me as a practicing pediatrician or an intensivist working in India when I see a sick child or a sick adult? And really what we show here is the severe dengue patients, as by the WHO dengue classification, are more likely to have high ferritin levels. They're more likely to have plasma leakage, more likely to present in shock, and they're more likely to have severe hemorrhagic manifestations. So really, your sick dengue patient who is presenting in shock, who may have hemorrhage, is more likely to be categorized as severe, is more likely to have high ferritin levels. And as demonstrated by Yaninge in the Malaysian cohort, those who do not survive, sadly, from dengue are the ones who have several-fold elevation. And if you cluster these patients, the cluster with the severe disease is the ones who have the highest levels of ferritin elevation. And it's the same heat map and cytokine map that they show. Again, you'll have to take my word unless you read this paper, that clearly demonstrating the homology with familial hemophagocytic syndrome and the significant elevation of some of these cytokines that they look for in those with hyperferritinemia associated with dengue infection. Randy Cron, who's joined the faculty, and several of his colleagues speculated about viral hemorrhagic fevers long before COVID hit our shows in 2015, of how certain viruses, be they Ebola or be they Marburg or Lassa or dengue, which tends to affect more populations, may represent a form of reactive secondary hemophagocytic syndrome. And again, why does it matter? Because of the reluctance of intensivists and infectious diseases pediatricians to use steroids or other immunomodulatory therapies. And these patients with dengue are usually managed only with supportive care. And so if we kindly shared this slide where she speculates with a colleague, Laura Ravino, on the pathophysiology or the pathogenesis of severe dengue, where there is some evidence of who progresses to severe disease. There's always the prospect of antibody-dependent enhancement, which is a major limitation to developing vaccines, and that the non-neutralizing IgG might facilitate viral entry. And then you have clonal expansion of T cells with low avidity for the current serotype, with a high avidity for previous infection, which really mediates the antibody-dependent enhancement, and the failure to obtain viral control because of probably defective apoptosis, which leads to this hypercytokemia, and the clinical manifestation of vascular leakage or capillary leak and tissue damage that most of you who treat these patients are familiar with. So where do we go? I'm plugging shamelessly a trial that Sophie is leading and I'm closely involved with, which is a trial of Anakindra for dengue patients. Of course, most of you who are listening in India are going to say that Anakindra isn't available, but here I'm demonstrating an example of trying to do a randomized double-blind placebo-controlled trial for dengue, and I urge you to do the same, be it for a low-cost option such as IV methylpred or oral steroids in dengue. And really, our hypothesis is IL-1 mediated pathways drive hyperinflammation and severe disease in dengue, and that using therapeutic IL-1 receptor blockade in selected patients with biomarkers which are suggestive that they will benefit from Anakindra will improve these outcomes. And alongside, there will be a host of mechanistic analysis to try and identify novel mechanisms and pathways which might represent future biomarkers or even therapeutic targets. So we have a host of aims. Really, the one which most of you might be interested in is, can we improve clinical outcomes in a phase 2 RCT of Anakindra in dengue patients with hyperinflammation? So how do we categorize hyperinflammation? We will categorize those with intermediate or severe dengue as those with ferritin levels of more than 2000, about the age of 12, because this is predominantly going to be an adolescent and young adult trial. We plan to recruit 150 patients in the hospital for tropical diseases in Ho Chi Minh City with this intermediate severe type dengue and signs of hyperinflammation. And our intervention is IV Anakindra 200 milligrams twice a day for 4 days versus placebo. Some of you may be aware that there is a trial of Anakindra which has been published where they used plasminogen, SUPAR, serum uroplasminogen activator receptor, as a biomarker in COVID, which shows significant efficacy, what's called the Save More trial, published in Nature, which I'm not going to review. But some of our therapeutic strategy is not dissimilar to that, and looking at doing this in emergency departments and ICUs in the hospital for tropical diseases. Primary outcome for most of the intensivists will be a delta of a modified SOFA score and looking at this change in the modified SOFA score over 4 days after randomization, but with a host of secondary outcomes, all of which highly relevant to our patient population, which is a 30-day mortality, similar to the 28-day mortality, which has become kind of the key primary outcome in all the COVID trials, number of days in ICU, number of days in hospital, number of serious adverse events, and then a host of biomarker changes. And really my key message, and I'm going to be challenged on this and happy to take questions, is dengue in a small proportion of children and adults does present as a secondary hemophagocytic syndrome. There is need to consider immunomodulatory therapies. We shouldn't arbitrarily dismiss steroids and other immunomodulatory therapies because of a few poorly conducted studies which did not demonstrate efficacy. And that's more down to the nature of the study, the absence of biomarker, the absence of stratification of these patients in the studies. And my acknowledgement to Dr. Balasubramaniam and Dr. Bala Ramachandran, Child's Trust Hospital, as well as Dr. Sophie Yakub, who kindly shared some of those slides on the impact of dengue globally. I hope that gives enough time for Yaningay to sort his glitches, and I'll stop sharing and take any questions.
Thank you, Professor Anand. That was indeed another excellent discussion. I myself have some personal questions to you. You are advocating very strongly the option of considering immunomodulatory therapy. You know, it's, as a general pediatrician, as somebody who's interested in infectious diseases, we have two problems when it comes to choosing such medication. We have starting trouble and stopping trouble. We don't know what to start with and how to start, and then when to stop it. So I want you to tell us, see, when you talk about immunomodulation, the cheapest immunomodulation I have is Dexamethasone, and the most expensive one is Anakindra as of now. And in between, we also have tocilizumab. You didn't mention about it, but I don't know whether it is relevant with regard to dengue. I want you to tell me at what point of time in a child with a diagnosis of dengue, I should start considering CRS. And second question is, when do I intervene? Third question is, what do I do? What is the choice? How do I choose?
Yeah, you probably know the answer as much as I do because some of the work we did together. And I think I don't want you to take messages from anecdotes. And I think I'd urge you to try and do a trial of steroids like they've done in recovery, which is possible given the huge number of cases of dengue. As you know, most of you see more cases of dengue than you see of COVID in your children's hospitals. Shouldn't be hard to do. But if I was being forced at the pain of death to make an answer, I would say if you have very high levels of ferritin, at least in the tens of thousands, as we did in that study almost 13 years ago, then it's perfectly reasonable in a resource-limited setting to consider the use of something like IV methylprednisolone in the right context after the appropriate supportive therapy has been given. It's not the reason I'm putting so many caveats is people will like me to say, oh, more than 10,000, I do this, less than 10,000, I don't do this. It doesn't quite work like that, but it's the context really. If you have got a severe dengue patient who is deteriorating in spite of appropriate immunomodulatory therapy, then certainly, as Yanninge has done in the Malaysian cohort and shown that there's a clear correlation between very high levels of ferritin and survival. So I think in your patients with ferritin of more than 10,000 with cytopenia who are not getting better in spite of your supportive care and other appropriate measures, then it would be appropriate to consider in the time frame where we're waiting to get evidence. I'm not recommending Anakindra because that's what the trial is about. I don't think we should be giving drugs without doing the trials, but I don't think you should always wait for others to do the trials as well. You will have the patient population to do the trials yourself.
What about combination of both IVIG and steroids? You know, we Indian pediatricians, we always want to do something to prevent infection and then give immunosuppressants. And that gives us a level of comfort. I know it's not really very scientific. You know, high ferritin, you give both IVIG and steroids. Is that fine?
Well, these are things which make you feel good, but I don't know necessarily if they're grounded in science. You know, IVIG and unless there's evidence, it's a very expensive option. It's in short supply, at least in the West. And I don't want to be willy-nilly recommending IVIG for all. There are putative theories where IVIG might mop up circulating antibodies working on the anti-idiotypes, but it would be better to do this in the face of some evidence rather than to do that just because it makes anyone feel comfortable.
Okay, somebody has asked, cutoff of 2000 for dengue trial may end up treating too many moderately sick dengue with Anakindra.
It's a great question, actually. And I think we did this based on, at least Sophie and I discussed this, and they did this based on what they saw in Vietnam. And I think it's a valid comment. It's one we have to be very cognizant of. But that's the value we've chosen based on the large cohort of adults with hyperferritinemia in the Vietnamese context we have seen. It might be different, but I would like to be shown some data from others showing that about 2000 is extremely common. I haven't seen such data, but happy to be corrected.
Somebody has asked, is timing of immunomodulation important? Any suggestions with respect to dengue?
Well, the first caveat is we haven't shown immunomodulation always makes it better. What I've shown you is that there are a cohort of patients who do badly, which you already know, that there is potentially a biomarker in ferritin which might predict poor outcome along with other things such as organ failure. When do you intervene? It depends on whether they are not responding to supportive care or not, and then carefully calibrating their clinical status with biomarkers. I don't think there will be a one size fits all single easy answer.
Somebody has asked a very pertinent question. Are there any risk factors for the poor general pediatrician on day 1, 2, 3, 4 to predict which of his patients is going to develop secondary HLH or MAS? Are there answers to this question?
I don't think there are, but that's what I'd urge you to try and find. I don't think you can predict that easily. There are some who do well and there are some who don't, but careful monitoring of the individual clinical status and biomarker. And I know most of these answers don't immediately address your questions, because I know, as someone who visits India regularly, as someone who works with you closely, that this is a constant clinical dilemma, that you find which dengue patient and when should we intervene and not. But I really would go back to, as we've always discussed, about calibrating the clinical status. And I think, I see a host of questions in the chat in the corner of my eye. I think we can't really do genetic studies. We know we can't really in a timely fashion do soluble CD25. Most of the time we can't do a marrow mesh. So we really have to work within the constraints that most of you face there, which is you have the clinical status and you have cheap biomarkers. And how can we stratify those cheap biomarkers to help address the needs of our patient population? And preferably, I think the need of the hour is a trial of steroids in a well-constructed randomized trial, rather than look at more unaffordable, expensive options such as Anakindra, or doing primary HLH mutation screening, which will all be interesting but incredibly hard to achieve in the resource-constrained environments that most of you operate in.
Okay, one more question. Do you recommend doing ferritin level in all cases of dengue? If so, on what day of illness will doing ferritin early, very early, be futile? Of course, my strong views on this. We had already discussed, but please answer this question.
Yeah, so I don't think you should do it in everybody, but in hospitalized patients at the time of requesting a full blood count, it's not an unreasonable proposition in my mind. But you shouldn't do dengue in someone who is not hospitalized and you're not going to do blood tests anyway. But if you do, then when you do a full blood count and look at the platelets, perhaps that's a time to consider doing a ferritin. Being relatively inexpensive, I wouldn't do it for its own sake, but I would do it at the time of monitoring. Most of you will monitor the platelet count, certainly in ferritin patients, and perhaps adding it at that time may not be unreasonable, in my opinion.
Okay, in fact, in our institution, we restrict to only those with severe dengue. We don't do in all those hospitalized for dengue. Anybody who goes to ICU, anybody who has severe dengue by the WHO classification, we do ferritin. Otherwise, we don't perform, because ferritin may come the next morning, by which time the child would be only on ORS. So even if it is high, we may not react.
Which is fantastic, actually. I mean, what you're doing is what's most appropriate. What I'm saying, it would give us some data on what happens in those who are moderately ill and then get better, which is what we don't have, which comes back to the question of, will we see a lot of moderates with more than 2,000? We don't know the true answer to the question, because as you rightly point out, you do what is exactly the right thing to do clinically in a resource-restrained setting, which is do it on only those who need it, which does leave us sometimes with a question which is more of academic value. Do moderate dengue patients who get better on just supportive therapy also have high ferritins or not? Of course, the best way to address that question would be to do it prospectively in a control setting, which doesn't cost the patient.
If time permits, one more interesting question is: in dengue HLH patients, is there a need to screen for genetic mutations?
Not in my opinion, but it depends on your access, your ability, and in a resource-restricted setting, I don't think I would do that.
Okay, over to Chandrika. That was fantastic. Thank you very much.
Thank you.
Thank you, Ram, for two wonderful lectures. So I think with this, we can go to Dr. Henter's talk next. And I request our panelists, there are many questions in the chat box and the Q&A box. It might not be possible for us to take up all the questions, but if time permits and if possible, please do answer the questions in the chat box and the Q&A box. Thank you.
Chandrika, do you hear me?
Yes, Dr. Hunter, we can hear you.
Yes,
You see the slide?
Yeah, please go ahead.
Do you see the slide moving?
Please make it full screen, sir.
Pardon?
Please make it full screen.
This is what it's on full screen in mine. So that's
okay. I'll broaden it, widen it.
Yeah, that's right. That's the thing.
I put it on full screen. It's really very difficult to understand why it's not in full screen in your presentation, because it's in full screen in mine.
Enable editing.
Yeah, make it full screen.
Can you enable editing?
Yeah, right to that. There is a column you can move forward. 64%. Make it 90% or 100%. Yeah. No. Make it around 75. That will be fine, because you're not able to make it full screen.
So this one may, okay, I go for this.
Yes, so you have to. No.
Is it good? Is it okay? Or smaller?
Smaller. Make it smaller.
Something like that.
Yeah,
and then I
will make it enable editing or slideshow. Enable slideshow.
But slideshow option. Slideshow. You press that button and try slideshow.
This is my push button slideshow.
Do you have two screens, Anakindra? Because you might need to just swap.
Not working. Okay, fine.
Your slides are moving now, Dr. Hunter, so I think we'll just go ahead with the talk.
Fine, thank you. Okay, I go for this. I'm sorry for this. I don't really understand why it doesn't show in full screen with you, because it's in full screen with me, but I go. So we start. What is HLH? So HLH stands for hemophagocytic lymphohistiocytosis, obviously. And as I said, we see this as an uncontrolled hyperinflammation, and it comes in two forms: primary HLH caused by inherited immune defects, and secondary HLH caused by underlying triggering factors. Primary HLH is treated with the HLH-94 and HLH-2004 protocols. That is basically with dexamethasone and etoposide. While secondary HLH is treated in two separate ways in parallel. One is by reducing the hyperinflammation, and how this is done depends on the trigger and the severity of the HLH. And then in parallel, finding and treating the underlying triggering factor. And then primary HLH, the inherited deficiency is in the immune downregulation, and basically deficiency lies in the cytotoxic lymphocytes and NK cells. This is 100% fatal, typically, with a median survival of only 1 to 2 months after onset if untreated. Secondary HLH comes in 3 major forms as we see it: infection-associated HLH, malignancy-associated HLH, and rheuma-associated or macrophage activating syndrome loss HLH. There are many, many other triggering conditions as well, as reviewed by Dr. Ramos Casals, but those are the 3 major ones. So with regard to the structure, I will start with primary HLH and then go for secondary. So basically it. And here are the diagnostic guidelines, as Ram mentioned. Either in primary HLH, you go for a molecular diagnosis, or 5 out of these totally 8 criteria. Many of these are available very rapidly in a clinical setting. 2 things I want to highlight. One is that hemophagocytosis is often not present initially and may never be present. So this is important. And the other thing is I want to highlight, but this as Ram already did, that hyperferritinemia is a very good indicator of HLH coming. And if you have a patient with some kind of unexplained inflammation, then you look for ferritin, and if it's high, evaluate the patient for various HLH conditions. So now, what have we learned then on the treatment of primary HLH. We've learned that early initiation of treatment is important in order to reduce organ-derived damage and to get the patient in a better clinical setting when we start. The second is that it has been remarkable what the effect of dexamethasone in combination with etoposide has had. The effects have been dramatic in improving survival. And we have now in the HLH 2004 study, over 80% of these very sick patients are surviving until transplant. The reason for transplant in this primary HLH cohort is because obviously the immune system is defect, so we have to kind of change that to a more healthy immune system. And this is a brief where I show you the HLH 2004 protocol. So we use etoposide, cytotoxic drug, twice weekly first, and then once weekly, 150 milligram per meter square. We use dexamethasone, initially 10 milligram per meter square, then lowering doses. We have also cyclosporine, but the effect of this is much weaker. And this is the first 8 weeks of therapy. I want to tell you some lessons learned on etoposide. First, in vitro. In vitro, it's been shown that etoposide can compensate for the inherited cytotoxic defect in FHL and normalize the apoptotic response in FHL patients in vitro. Then in vivo, in a murine model of HLH, etoposide was shown to substantially alleviate all symptoms of the murine HLH, and the therapeutic mechanism involved a potent selective deletion of activated T cells and efficient suppression of the inflammatory cytokine production. And more recently, in humans, it's been shown, and I think this is interesting, that etoposide promotes the programmed nice cell death, apoptosis, rather than the pro-inflammatory lytic cell death, pyroptosis, conceivably ameliorating subsequent systemic inflammation. These are very recent studies. Another lesson is that in a majority actually of the primary HLH patients, we see CNS involvement, either with neurological symptoms or abnormal CSF. And therefore, we urge that prompt treatment of active HLH at onset or relapse is essential in order to reduce neurological sequelae. And I want to highlight that I think that this knowledge can be implemented in secondary HLH as well. So lessons learned then on the immune system regulation. So familial HLH is a defect in immune regulation. And the defect lies in the cytotoxic lymphocytes within the peripheral system, which is then obviously central in human immune regulation. And this was not known until these studies in FHL were performed. So we now know that cytotoxic lymphocytes have 3 major functions. One is to eliminate virus-infected cells, to eliminate cancer-transformed cells, but also then to downregulate the immune system. And if these functions are defect, there will be hyperinflammation, that is hypercytokemia or cytokine storms. So here we have the cytotoxic T cell. In these vesicles, we have granules with perforin. Perforin is released from these cytotoxic cells or NK cells and perforate then the cell membrane of the target cells and induces apoptosis of the target cell. In more detail, the inherited defects are several genetic defects. So one is that you have to have the perforin gene has to be functioning in order to make perforin. But then there are several other genes, UNC13D, syntaxin 11, syntaxin binding proteins. They're all necessary for the docking and priming and fusion of this vesicle with the cell membrane in order to get the perforin out of the cell, and we call this move of these granulars for degranulation out of the cytotoxic cell. So there can be deficiencies here as well. And we can then use this biology in the diagnostics of HLH, either by cytotoxic assays, analyzing degranulation, as we mentioned, or you can stain intercellular for perforin or other proteins. You can study the cell NK cell activity, although this is only rarely available. I agree. And then you can study the numbers, NK cell numbers and CTL numbers, or obviously genetic tests. So that's primary HLH. Now let's move on to what we've learned on how we can use this knowledge in secondary acquired HLH. And we'll start with infection-associated HLH. And the most common here, I think, is, although dengue is very common as well, probably at least most known is the EBV HLH. EBV HLH has a high mortality. And it's been shown that steroids and etoposide have dramatic effects. This is an early slide from Japan. Early etoposide treatment, high survival, low or late etoposide, low survival. Later findings shown that in EBV HLH, all patients do not need etoposide, which leads to the current, I think, the current Japanese protocol, and they are very good in EBV HLH. In what they call low-risk patients, they start with dexamethasone only. And then in intermediate risk, that is in patients with fever still after 48 hours, then they add etoposide and cyclosporine. And then what they call high risk is patients less than 2 years or with increased EBV DNA load, or more than 1,000 copies per ml, they add rituximab. But etoposide is essential in this treatment of this viral induced HLH. So I have just one slide of COVID-19. I want to say two things. One, that I'm very grateful that the recovery study in the UK, that they actually included dexamethasone, that we found so valuable, that they included that in their study, and that they were able to show that the use of dexamethasone is saving lives and reducing mortality. And also then that this COVID steroid 2 study have shown that higher amounts of DEXA, 12 milligram instead of DEXA, appear to have possible probabilities of benefit and low probabilities of harm. So we are getting closer to what we use in HLH 94 and 2004. This is a very odd slide, but I wanted to, for you, I think, but I wanted to raise my curiosity on how about using etoposide as salvage in COVID-19. There are very few studies, but there is a Spanish study on 11 patients. I thought this is very interesting. So this is patients with no response to 3 days of methylprednisolone, in addition to having had either tocilizumab or Anakindra. In addition, respiratory insufficiency and hyperinflammation, ferritin more than 1,000. And they recognized a prompt response to etoposide in these patients after only 1 or sometimes 2 doses. The oxygenation improved markedly. There was a reduction of the need of vasopressors, reduction of respiratory support, very low hematological toxicity, and high survival. And in this image, they show that when patients were given etoposide, the oxygenation increased, as you see here in several patients. So they showed that this was efficient, and I thought that is very interesting. There are other HLH triggering infections, such as dengue, and Ram has told us so many interesting things about that, so I will not add much to that, except saying that we recognize that 40% in this Malaysian study that Ram mentioned, 40% of the patients with at least 4 diagnostic criteria for HLH, 40% of these patients died. And we think, at least I think, that this high mortality is an indication to at least consider prompt HLH-directed therapy in severe dengue patients with hyperinflammation and evolving multi-organ failure. What this HLH-directed therapy should be, we need to know. Could be steroids, Anakindra, etoposide, we need to know that. But there is a need, I think, for a immunomodulation in these patients. I can also mention that we've recognized in pandemic influenza, patients may develop HLH, or they are low percentage. And there are other viruses as well that we don't have time to go through that reviewed here in this presentation. Now I want to go into a very difficult area, which is bacteria-associated HLH. I have one case report I want to tell you. This is a premature child, 732 grams, that at 1 month of age developed Serratia septicemia. Massive hepatosplenomegaly, highly elevated bilirubin, pancytopenia with neutrophils 0.1 and platelets 4, elevated ferritin, and other signs of HLH. And we gave this child first steroids, and since I didn't have effect, also etoposide, which with a prompt response, and there were no genetic defects. We stopped therapy, and the child survived. So there were no underlying primary HLH in this child. But I also want to tell you, and I think this is important to be aware of, that is a time difference between the onset of the septicemia. So you have the CRP here around day 30, above 300, but this bilirubin, as a mirror of liver involvement in HLH, had its peak couple of weeks later, that is around day 45, when we started steroids. And then here later on, red arrow, we started etoposide, and then the bilirubin started to decrease. So now let's over to malignancy associated HLH, which is the third most common form in children. So first, infection associated, and in children, then macrophage activating syndrome is the second most common, and malignancy associated HLH is the third most common. But in adults, the malignancy associated is along with infection associated are the two most common forms. So malignancy associated HLH comes in two forms. One is before the cancer therapy. So here it is the malignancy that triggered the HLH, malignancy triggered HLH. And then it comes during chemotherapy, second form, HLH during chemotherapy. I have one message here, take-home message, that if you have a patient and you don't find the underlying cause of this presumably secondary HLH, search and search and search again for an undetected malignancy, most typically lymphomas. And one slide then on treatment of malignancy-associated HLH. So in case there is organ damage that is HLH triggered, we suggest a two-step approach, with the first step being to target the cytokine storm and the T-cell proliferation using very moderate doses of etoposide, 75 to 100 milligram per meter square, in combination with corticosteroid and possibly IgG. And then there's a second step, target the neoplastic disease by specific treatment. So one of the main slides here is on the lessons learned, that there is in secondary HLH, there is a need for a graded intensity and a graded length. So moderate cases, you may only need steroids with or without IVIG. And personally, I don't think IVIG makes that big of a difference. But in severe, persistent or relapsing HLH, or in case of CNS involvement, consider a modified HLH protocol such as HLH94 or HLH2004. And the modifications that I want to highlight is, first of all, less frequent doses, not twice weekly as in the protocol, typically once weekly or maybe even less. Then a shorter duration, sometimes only 1 or 2 or 3 doses will be sufficient, and you decide that on a weekly basis, depending on the response of the patient. And thirdly, a lower dose. So in children, 50, 75 to 100 milligram per meter square. Sometimes, but more rarely, we use 150 milligram per meter square. And in adolescents and young adults, even less. And finally, very few words on macrophage activating syndrome, MAS-HLH. We will talk about that later during this conference, and Dr. Krohn will talk about things, and you know the regular treatments. What I want to highlight is that I would like to add one more tool to the toolbox of MAS-HLH and present to you this study on 7 children with rapidly progressing MAS-HLH with CNS involvement or pulmonary involvement that did not respond to ordinary treatment. And we added moderate dose etoposide, 50 to 100 milligram per meter square, once weekly to these patients, to the conventional MAS treatment. So this is 1/3 to 1/6 of what we do in the ordinary protocol. So this is a very moderate dose with moderate side effects. All children survived, CNS symptoms normalized in 4 out of 5 children. So we conclude that moderate dose etoposide may be beneficial in severe and/or refractory MAS-HLH, but don't wait too long. And this is one slide showing you this in more detail. So this is a boy. He had oral corticosteroids, cyclosporin A, Anakindra, and despite that developed flare of MAS-HLH, had methylprednisolone pulses, 3 pulses, responded partly to that, but then again, ferritin up to over 30,000, did not respond to second course of pulses of methylpred. So he was given etoposide, and as you see, already at the first stop, we stopped the increase of ferritin and one day after he started declining his ferritin very promptly like this. Here he was given another dose and then some subsequent doses. And one additional lesson I want to tell is, I think this was wrong. We gave him too many doses. This was not needed. He would need 1 or 2 or maybe 3 doses at the max. So as a summary, implementing knowledge on primary HLH and secondary HLH. First, etoposide promotes apoptotic rather than pro-inflammatory cell death. The combination of dexamethasone and etoposide has been very efficient, and there have been many lessons learned on the primary HLH that have been implemented in secondary HLH. And I will stop there. I will thank the collaborators in the HLH studies. My collaborator is Karinska. Thank the organizer for the invitation, and I thank you for your attention. Thank you very much.
Dr. Basraj, you would like to take the questions?
Yes, sir. Yes, sir. Thank you so much, Professor Enter, for an excellent overview on what we really learned from a primary HLH and how we can implement it in the secondary things. It is a wonderful talk. So there are a few questions. Just I'll take up one by one. One of the questions from Dr. Anand Prakash, he is an haemato-oncologist. Is there any role of a low dose etoposide of 50 to 75 milligram per square meter rather than 150 milligram in an infant? How was the dose of 150 has been decided on?
In which kind of disease was that? I didn't get in what kind of disease was that? In what setting?
Yeah, that is related to the, especially should be dose of etoposide to be decreased in case of an high bilirubin also.
I think Dr. Anand Prakash is one of the panelists, so he can ask the question himself.
Yeah.
Actually, he has asked whether there should be any dose adjustments if there is hyperbilirubinemia. Etoposide dosage adjustment in hyperbilirubinemia.
No, the answer is I don't think so. This is we have not seen that. Maybe in combination if there is also renal insufficiency, but not only in bilirubin. Okay.
Okay. One of the questions from Dr. Chitra Dinekar, is the low dose of a steroid is an option? You have already shown that in your presentation. Can you throw more light onto that dose of a steroid?
I'm sorry, I didn't fully get the question. It's a low dose etoposide in which setting again? So please.
No, low dose of a steroid in an HLH. Low dose of a steroid in secondary.
Steroids. low dose dexamethasone or methylprednisolone in HLH. Is that an option?
Yes, but so I think that dexamethasone is a very good option in many cases of HLH, and possibly also, as we talked, in dengue HLH. So there is a, but I don't think it needs to be a low dose. I think the steroids you can have quite a good starter dose, because you need to push the hyperinflammation down promptly and fast.
Dr. Chandrika Bhatt had asked whether there is any relationship between the use of etoposide and future malignancies.
There is a very limited, we have looked into that in the big HLH 94 and big HLH 2004 studies. And there is a very limited, like 0.3% correlation. However, it is possible that these are patients that have had malignancies from the beginning that were not identified. So in these very short courses, we see this risk as almost zero, very limited. And in relation to what we gain, it's very limited.
Non-malignancy, non-genetic HLH, initially diagnosed, do you recommend both antibacterial and antifungal prophylaxis routinely or not?
Yes, we do. I haven't had time to that, but both of them are needed. Fully a good point. And I actually would like to highlight that for some reasons, we see increased risk of fungal infections in patients with HLH, primary, maybe more primary HLH. I have no data on secondary HLH to be confirmed, but fungal prophylaxis as well. Yes.
Yeah, one of the questions from Dr. Vijay Gauri. What's your experience with the JAK inhibitor in HLH?
Yes, so this is a very interesting question. There are studies done in mice showing efficacy, and there is one study from Minneapolis or Minnesota, I think, or at least northern US, where they have shown some efficacy in a limited number of adult patients. There is a study from Philadelphia starting up for children with primary HLH or with HLH primary and secondary, but so far there are a limited number of patients with JAK.
One of the questions from Dr. Sushma, can the tocilizumab be used in a secondary HLH if there is no response to the steroid?
Could you take that
again? Yeah.
Once again, take the question once again, please. Yeah.
Can the tocilizumab be used in the secondary HLH if there is no response to the steroid?
I have limited experience of that. What I think is that, Anakindra is obviously a good drug for many patients. I have more experience with Anakindra than tocilizumab, but Anakindra we use sometimes and find that valuable in many patients. I also would like to see that, in my view, I think etoposide is even stronger, but sometimes the value of Anakindra is that you don't get the neutropenia, and that's also sometimes very valuable. So Anakindra is a good choice. I know less about tocilizumab.
So when it comes to the steroid, Dr. Sridevi is asking, which is the better? Is it a methylprednisolone or is it a dexamethasone? Is there any difference in the steroid in HLH?
The reason that we have gone with dexamethasone is that it penetrates the brain better. And because we have so high percentage of CNS patients with CNS involvement, we want to get the drug into the brain as good as possible. And that's why we've chosen dexamethasone. That's the reason. We have not any studies where we compare the two.
Cyclosporin versus etoposide, how do you choose?
We have, so the HLH 2004 had more of cyclosporin, particularly earlier, and we did not find that much of a difference. So my view is that cyclosporin does not have a strong effect, while etoposide has a very strong effect. So cyclosporin has less value, and I think actually, for instance, Anakindra is more valuable.
I think we are already running half an hour late. So in the interest of time, if we could move on to the next session, if that's okay with everyone.
Yeah, you can go ahead, Chandika. Thank you.
Right.
Thank you very much, Professor Hector, for an excellent overview. Thank you, Professor Raman, sir, for an excellent talk.
So,
thank you.
Thank you, SBS, sir, for your input.
Thank you.
Yeah, so thank you to the chairpersons and our amazing faculty for the wonderful opening session. I think with this, we'll move on to the second session for the day. And for this, I would like to invite our chairpersons, Dr. Praveen Khilnani and Dr. Sujata Sani. So Dr. Praveen Khilnani is a senior consultant in pediatrics, and he's the director of intensive care at Rainbow Children's Hospital in New Delhi, India. We welcome you, sir. And Dr. Sujata is a senior consultant in pediatric rheumatology at Gangaram Hospital in New Delhi. She has multiple publications to her name and has been the editor of 2 textbooks in rheumatology. And her key areas of interest are childhood lupus, JIA, and ultrasound in pediatric rheumatology. We welcome you, ma'am, and over to you for the next session.
Thank you so much. We are quite late, so I will not take much of your time. I would like to introduce the first speaker for the session, Dr. Pooja Mehta. So Pooja is a senior specialist registrar, is currently doing a basic science PhD in post-COVID interstitial lung disease at the UCL in London. And she likes to look at multidisciplinary teams and their role in the management of ILD. And she runs specialist ILD clinics and also is interested in ILD radiology. She is a member of the task force of EULAR for COVID-19 and is a current clinical chair of the Early Career Research Network Committee and member of the SWAN Committee at UCL. She supervises and teaches MSc and medical students at UCL and Imperial College London. So with those words, over to Dr. Pooja Mehta.
Thank you so much. Can you see my slides in presenter mode?
Yes.
Perfect, excellent. So thank you very much for the very kind invitation. And I'd like to start by first thanking the organisers for the invite. I've never been to Bangalore, but my parents have often talked about it and how beautiful and peaceful it is. And I think we all need that right now. Very happy to join you virtually today and hopefully maybe one day in person. These are my disclosures, to which I would add I'm not a paediatrician, and therefore I'm looking forward to learning a lot about paediatrics, but I'm an adult rheumatologist. So by way of overview, we'll begin with the hypothesis of hyperinflammation in COVID and why it was controversial. I'm going to very briefly cover the background of established cytokine storms. We've heard a lot about that already, so I'm hoping not to duplicate, and we're already running over. I'll move on to COVID hyperinflammation and end with future directions, unanswered questions, and lessons from COVID-19. Wondered whether hyperinflammation was contributing to poor outcomes in some patients with COVID early on in the pandemic, given that there were clinical similarities to secondary HLH. Viruses are the most common infectious trigger of secondary HLH, and in this study of 2,200 adult patients, infection was the driver in half of patients, and viruses accounted for 70% of the causes. And most commonly, this was EBV, HIV, herpes virus. Early reports from China provided some scientific rationale, a cytokine profile and biomarkers known to be important in SHLH associated with COVID disease severity and predictors of fatality. And with that rationale in mind, at a datapenic time, quite early on, we suggested that all patients with severe COVID should be screened for hyperinflammation. We now know that the H-score is not useful to identify this group of patients and that IVIG or convalescent plasma are not effective. But we've come so far, and we do have evidence for the efficacy and safety of steroids, tocilizumab, JAK inhibitors, and even Anakindra in certain populations. We weren't the only group to suggest this concept, and there was a very nice paper along the same line by Lauren Henderson and colleagues around a month later. Controversial at the time that we suggested it, and the proposal that hyperinflammation was involved in the etiopathogenesis of severe COVID was useful. It served as a catalyst for numerous clinical trials of immunomodulatory strategies in this space. But like any hypothesis, this was appropriately challenged, and there were some Twitter storms as well. Some questioned the definition and the low IL-6 levels. They highlighted concerns regarding the risks of immunomodulation with potential viral resurgence or bacterial or fungal superinfection, the risk of compromising antiviral immunity in this virally driven hyperinflammatory condition, And with respect to previous pandemics with coronaviruses, worse outcomes had been observed with steroids. We were also accused with potentially distracting focus from antivirals and vaccines. And I think there's been a lot of discussion about the terminology earlier on, and the terminology of hyperinflammatory disorders was debated again in COVID. The term cytokine storm has been quite emotive and polarizing. And Professor David Feigenbaum and I recently reviewed the hyperinflammatory debate. A fast-track systematic literature review and meta-analysis with a very large number of patients compared IL-6 levels in COVID to other critical illnesses. And indeed, the mean serum IL-6 in patients with severe or critical COVID was low, only 36.7 picograms per mil. And IL-6 levels were so much higher in other critical illnesses, especially cytokine release syndrome post-CAR T-cell therapy. However, it's important to remember that the focus here was only on IL-6, and systemic levels may not accurately reflect the local disease microenvironment, the pulmonary compartment, which we know that COVID really is a cytokine storm, largely confined to the pulmonary compartment, although we've heard about other organ manifestations as well. And this figure here shows that the IL-6 levels in COVID in purple are significantly higher in the bronchoalveolar lavage, the BALF, compared to the blood. And we all know from rheumatology practice that IL-6 levels and indeed CRP do not correlate with response to tocilizumab. We've had a nice background on cytokine storms already, so I'm going to cover this very briefly. And a recent definition of cytokine storm was proposed in the New England Journal. And severe COVID-19 would meet this definition, so immune dysregulation, elevated cytokines with deliberate omission of specific cytokines or thresholds given the dearth of data, acute systemic inflammatory symptoms, and secondary organ dysfunction, any organ, disproportionate to the initial trigger. We've seen this umbrella already. The cytokine storm or hyperinflammation is a unifying catch-all. And here we have COVID-19 as a distinct entity residing under this umbrella term. The etiopathogenesis of cytokine storms are not fully elucidated, but are thought to occur in an immunogenetically susceptible individual, where a trigger, such as a virus, results in dysregulated immune activation, exaggerated autocrine loops of cytokine storms, the pro-inflammatory cytokine storms listed here, that give rise to the clinical sequelae. And all of these targets are druggable with existing therapies with known side effect profiles. In our review, in a management framework, we proposed switching off the cytokine storm with immunomodulation in an induction maintenance treatment paradigm. The Anakindra dose ranges are variable in clinical practice. We tend to start high, then taper after a response with corticosteroids in consideration of intravenous immunoglobulin. Concurrently, we should treat the underlying cause, for example, antibiotics and sepsis. And there's been a lot of talk about remdesivir antivirals with COVID and treating and preventing complications. And we've just heard about antifungal strategies. Now, why is this important? Well, HLH has a huge unmet need, high mortality, it's underdiagnosed and undertreated. The all-cause mortality is around 40% in adults, highest with malignancy, but also high, up to 20% in patients with rheumatic causes. And the mortality is high not only because these are very sick patients, but also because of delays that we can improve. Delays in diagnosis, delays in initiation and escalation of treatment. And COVID-19 has taught us so many lessons that we need to learn to improve the care of patients with HLH. So let's talk about COVID. How do these concepts relate to COVID? Well, a biphasic model of COVID-19 is now well established, with an initial viremic phase followed by an overlapping host hyperinflammatory phase at around day 10 in a subgroup of patients with an exuberant dysregulated immune response with a very high mortality. And this is hands down my favorite figure of the pandemic because it's so simple but so effective, elegantly encapsulating the complexity and need for strategic timing of immunomodulation to minimize harm and maximize benefit. The immune response in COVID may be helpful with antiviral immunity or harmful, hyperinflammatory, and it feels like there is a Goldilocks immune response. Too weak, where there's dominant viral damage to the host, too strong, where there's hyperinflammatory host damage to the host, and just right, where there's an appropriate host antiviral immunity and symptoms are mild to moderate or controlled. There are multiple therapeutic opportunities for intervention with antivirals, antithrombotics, immune suppressants, and immune stimulants. And nearly all of these have been trialed over the last 2 years with an avalanche of trials in this space. So although severe COVID has features suggestive of cytokine storm with fever, raised inflammatory markers, and ARDS, it didn't fit the criteria for established cytokine storms that we've heard about already, Hlh 2004, the H score, and the mass SJAA criteria. We had difficulties in assessing for organomegaly in these patients who were very unwell on ITU and resources were poor and conditions were stretched around the world, or even hemophagocytosis, as bone marrows were very difficult to obtain. And we must remember that bone marrow hemophagocytosis can be expected in critical illness. Hypertriglyceridemia was also confounded by propofol use, as my intensive care colleagues tell me. These patients were very difficult to sedate, requiring very high doses of propofol, which can cause a secondary hypertriglyceridemia, which is a pseudo hypertriglyceridemia. So clinically, these patients appeared very different: lung dominance, immunothromboses, significant lymphopenias without other cytopenias, high CRPs, but ferritins much lower than reported in secondary HLH. Now, we already have a very robust score to predict risk of mortality and deterioration in hospitalized patients, the ISARIC 4C, which is based on a massive discovery and validation cohort from over 57,000 patients all across the UK. And they included age, gender, comorbidities, clinical and laboratory criteria, including the CRP, but we need to identify the subgroup of patients with hyperinflammation to ultimately predict response to immunomodulation. And 3 large studies have tried to do this. These are all observational with different approaches to define the criteria, using multidisciplinary team review, literature review, and empirical derivations. Important to remember here and to note that the traditional conventional scores, Hlh 2004 and the H score, performed very poorly in COVID, and therefore this was very useful endeavor. Taken together, the 3 studies differ in complexity and parameters and thresholds used to define hyperinflammation. For example, the ferritin thresholds range from 250 all the way to 1500 nanograms per mil. The Temple criteria, where most patients were on steroids, and the only score that required a pneumonitis on chest imaging, included markers of electrolyte imbalance, whereas COV-HI focused only on inflammatory markers. Very interestingly, the CRP, which I'll come to later, had no discriminatory power in Temple or His scores, but was the focus of COV-HI. So how do we know if we're identifying hyperinflammation or just severe disease? The definitions of hyperinflammation were somewhat arbitrarily defined by either expert consensus or literature review, potentially introducing a confirmation bias. And we really do need independent validation of these criteria in other cohorts. However, this is going to be challenging given that standard of care definitions have changed over time, and therefore currently all 3 of the scores, despite being very useful, clinically in terms of translatability, the role is unclear. Clinically, the COVID-19 hyperinflammation phenotype appeared different, but also immune profiles and cytokine signatures are also different, as shown by Christoph Kessel and colleagues, who compared COVID-19 patients from the first wave to secondary HLH, MAS, and healthy controls, aiming to identify distinguishing serum biomarkers. And these are some figures showing unsupervised clustering analysis, revealing distinct groupings of patients. So the first principal component analysis on the left, PCA, discriminated patients with COVID-19 critical disease in orange from moderate or severe disease, which clustered with healthy controls in blue. In the second figure, patients with SHLH MAS, the big pink circle, clustered separately from patients with COVID. And in the third, patients with SHLH MAS in pink was distinct from patients with SHLH in pink were distinct from patients with MAS. 6 serum markers were able to distinguish patients. Levels of IL-18 and interferon gamma were markedly elevated in those with SHLH MAS compared with COVID. Soluble Fas ligand was strongly decreased in patients with COVID compared to both healthy controls and Sh/Hlh MAS, and serum concentrations of IL-1RA, which is a marker of inflammation, ICAM-1, which is a marker of endothelial dysfunction, and IL-8, which reflects pathogenic features of ARDS, encouraging neutrophil recruitment, was significantly increased in patients with critical COVID compared to those with Sh/Hlh MAS. And the markers that I've indicated with a red asterisk had identical performance in separating critical COVID from Sh/Hlh and MAS early or late in the disease course on longitudinal samples, and of all the markers, interferon gamma performed the best. Now, IL-18 and interferon gamma have a central role in antiviral defense, but also in the pathogenesis of hyperinflammation. IL-18 and interferon gamma had a positive correlation with almost all of the quantified markers with patients with Sh/Hlh MAS, the heat map on the left, which is largely red, showing positive association, whereas they did not observe these associations in patients with critical COVID, the heat map on the right, which is largely blue. So, together, coming back to the clinical question, is acute severe COVID-19 a cytokine storm? And Professor Ramanan alluded to this question before because it isn't entirely clear, but hopefully will become clearer as we discuss the concepts through the course of this presentation and in the discussion. So first of all, do positive or negative immunomodulatory trials support or refute the concept of a cytokine storm? This has been much debated, and it's not straightforward to celebrate or commiserate a so-called positive or negative trial. And positive and negative, you'll notice, is in inverted commas because it all depends. A lack of treatment response does not always refute a cytokine storm because the efficacy of a treatment is likely to depend on a number of factors, including patient selection and severity, timing with a potential window of opportunity that we illustrated in this figure. Intervening too early may be harmful. There was a suggestion of worse outcomes with dexamethasone in patients not requiring supplemental oxygen, and intervening too late may be futile. Dosing is probably best exemplified by Anakindra. IV dosing of Anakindra results in a higher 29-fold and faster maximal plasma concentration, Cmax, than subcutaneous delivery. These concepts were very nicely represented in this figure in the Lancet Respiratory Medicine, demonstrating the IL-6 blocking studies in COVID-19. And there seems to be a swinging pendulum of positive in orange and negative in grey studies. And remap, cap, and recovery seem to have captured that sweet spot. COVID-19 has brought so much attention and research to this area. And for me, the emerging pro-inflammatory immunoregulatory cytokine GM-CSF that we've heard about earlier exemplifies the complexity and challenges of drug trials in COVID. There is rationale for both therapeutic blockade as well as recombinant administration of GM-CSF. GM-CSF has important roles in homeostasis, antiviral immunity, as well as hyperinflammation. And I wanted to point out that activated macrophages and Th17 cells are potent producers of GM-CSF. GM-CSF is interesting as well when we talk about virally driven hyperinflammatory disorders. And this study compared patients with COVID and influenza. GM-CSF, IL-6, and the interferon surrogate, CXCL10, were associated with COVID disease severity, markers of endothelial injury and thrombosis, and was shown to have a pathogenic role in both COVID-19 and influenza. However, when looking at fatal influenza and GM-CSF, historical samples that had been retrieved from patients that unfortunately passed away with influenza, whilst IL-6 was equally elevated in both fatal influenza and fatal COVID, GM-CSF was only prominent in fatal COVID, suggesting that it has an important role in COVID-19 pathogenesis rather than influenza. So this is important when we think about the big picture and looking at hyperinflammatory disorders on the whole. It's so important to tease out the differences as well as the similarities. There's more to poor prognosis than just hyperinflammation. We all know that poor prognostic factors in COVID include male gender, age, comorbidities like diabetes, for example, possibly because of a pre-existing chronic inflammatory state or a lower threshold for the development of organ dysfunction. We talked about HLH being a condition that may occur in an immunogenetically susceptible individual. And a GWAS study from over 2,200 patients from the UK showed that critical illness in COVID is related to at least 2 biological mechanisms: innate antiviral defenses, which are known to be important early in the disease course, and host-driven inflammatory lung injury, which is a key mechanism of late life-threatening COVID. Type 1 interferons are also central to the immunobiology of COVID. Autoantibodies directed against, as well as loss of function variants in type 1 interferon immunity, are associated with life-threatening COVID-19. And there's also a very high prevalence of functional autoantibodies against a range of immunomodulatory proteins, which confer poor prognosis. So can we finally answer the question? Well, there are arguments for and against this concept. There are increased cytokine levels in COVID-19, which are associated with poor outcomes, but are these needed for antiviral immunity? And levels are modest compared to other critical illnesses. COVID hyperinflammation is different to established cytokine storms. There are new criteria, but there's still more work to be done. And the beneficial effects of immunomodulation do suggest that inflammation is a modifiable pathogenic component of COVID, but removal of cytokines with cytosorb led to worse outcomes. And there are other host factors. Longitudinal studies show that there are worse outcomes with low viral loads and high anti-SARS-CoV-2 antibodies, but we cannot ignore the contribution of other host factors such as genetics. So let's take a step back and look at the big picture. SARS-CoV-2 can trigger a range of inflammatory syndromes and subtypes across the age spectrum. With respect to hyperinflammation, adults may develop this acute COVID-19 hyperinflammation that we've talked about: pneumonitis, immunothromboses, within about 10 days of exposure to SARS-CoV-2. Both children and adults can develop delayed hyperinflammation, multisystem inflammatory syndrome in children, MIS-C, or as it's known in other parts of the world as PIMS-TS, or in adults, MIS-A, weeks after the initial mild asymptomatic infection, which may be due to abnormal antibody responses that drive systemic hyperinflammation. And also classical secondary HLH may be triggered by COVID-19. A systematic literature review showed that MIS-A, which occurs in adults, this delayed hyperinflammation, usually occurs in young males, previously fit and well, about 4 weeks after the acute onset of COVID-19, with extrapulmonary multi-organ dysfunction. And this is a very sick group of patients. 60% require intensive care unit support with a very high fatality rate. Interestingly, inflammation may be a component of long COVID, and at 6 months follow-up in around 1,000 patients, there were 4 phenotype clusters of patients that were identified, mild to very severe on mental and physical impairment. And we're learning more about long COVID, but the proportion of patients with a raised CRP above 10, which I've shown in the orange bars, increased with severity of long COVID. And finally, some very rare vaccine-related inflammatory adverse events like myocarditis may be inflammatory in a section of COVID-19 inflammation. So let's end now with future directions. What next for COVID-19 hyperinflammation? Well, we really need to move forward towards precision medicine approaches to optimize treatment outcomes. We've talked about CRP, but it's really not clear. A raised CRP may predict better responses to steroids. In one study, the odds ratio of mortality or invasive mechanical ventilation, IMV, with steroids fell with higher CRPs above 200. And another study showed improved outcomes with corticosteroid use if the CRP was greater than 100, better outcomes still if patients were hypoxic in addition. The role of CRP with respect to tocilizumab is unclear. The recovery inclusion criteria stipulated a CRP of greater than 75, and in REMAP-CAP, terciles of CRP levels did not correlate with treatment responses. So maybe it's not CRP at all and is something completely different. Well, SUPAR is the soluble urokinase plasminogen receptor and is emerging as an interesting biomarker of inflammation, organ damage, and immunosenescence. And in COVID, SUPAR may be an earlier predictive biomarker of poor outcomes compared with CRP and ferritin. SAVE MORE was a phase 3 trial of Anakindra in around 600 patients with COVID enriched for SUPAR, and around 80% of patients had steroids. Anakindra was associated with a fall in the World Health Organization clinical progression scale, lower SOFA scores, which are a marker of disease severity in intensive care settings. Anakindra also was associated with a lower 28-day mortality and length of hospital stay. And I just wanted to mention that in this very selective population enriched for SUPAR, there was a fairly low baseline CRP, IL-6 and ferritin, and CRP or ferritin did not predict a treatment response to Anakindra, and therefore it's not straightforward. So what can we learn about non-COVID hyperinflammation, and what are we going to do next? COVID-19 really boosted hyperinflammation research, and there seems to be a zeitgeist moving towards disease-agnostic approaches, which might make the confusing terminology that we've heard about earlier redundant. This is a shameless plug for our international cross-specialty HLH MAS survey of practice. It's the QR code. I'd be really grateful if you could kindly fill the survey in, which hopefully should allow us to formulate clinical guidelines. Risk stratification is really important. It's not just coronavirus at play. The PROVIDE trial is a trial of Anakindra in sepsis that we're eagerly awaiting. Recombinant interferon gamma was used in the hypoinflammatory subtype. And we've heard about dengue already, exploring Anakindra and potentially JAK inhibitors in this space. You may also recall that ARDS resided under the beautiful cytokine storm umbrella that we saw earlier in Scott Canner's figure. And with my joint first co-author, Romit Samanta, who's an intensivist, led by Professors Danny Macaulay and Cecilia O'Kane, who are intensive care medicine and pulmonary specialists, respectively, which is an example of cross-specialty collaboration, in a discovery and validation cohort from 2 randomized controlled trials in ARDS, we've identified a ferritin threshold of 1360 nanograms per mil associated with increased mortality, systemic inflammation, and inflammasome activation. And as a teaser, IL-18 was increased in hyperinflammatory ARDS and hopefully should inform interventional studies in ARDS. So in conclusion, our hypothesis was a very early data-deprived statement as cytokine storm as a mechanistic basis of critical COVID-19 pathogenesis. And given the success of immunomodulation, it's now widely accepted that a subgroup of patients with severe COVID have a dysregulated hyperinflammatory immune response. It doesn't matter what we call it, but they have a dysregulated immune response. Hyperinflammation in COVID is a new and distinct entity, and several criteria have been proposed, but we need multivariate models and immune profiling. And we really need to apply all the criteria to a large data set to see if we can predict treatment responses. Biomarker discovery needs to move from prognostic to predictive, and we've talked about SUPAR as an interesting companion biomarker for Anakindra. And we mustn't forget that there are other important host factors contributing to poor prognosis like genetics. Cross-specialty collaboration really is key, and there is still so much work to be done and unanswered questions. How does the pattern, severity, and mechanism of hyperinflammation in COVID influence endothelial activation and hypercoagulability? What is the impact of immunomodulation on clinical thrombotic outcomes, which we've not discussed today? And what is the impact of hyperinflammation in the acute phase on complications in the convalescent phase of long COVID, which is really a huge burden on global healthcare? And it's unclear if variants or vaccines will modulate the occurrence or presentation of hyperinflammation in COVID. I just wanted to end by dedicating this talk to Professor Amit Patel, who was a dual accredited professor in haematology and intensive care medicine in the UK, who gave a talk at the Indian Rheumatology Association in the year before he died. And he really was an inspiration and a long-standing mentor and friend. And I want to also thank several people who've inspired and encouraged over the last 18 months, and thank you for your attention.
So thank you very much, Pooja. Dr. Chandrika, do we have time for questions, or do you want to take them in the end?
I think we can take them in the end, if that's okay.
Thank you very much, Pooja. That was a brilliant talk, and I must say that your clarity and your delivery was excellent, as was your material. So thank you so much.
Thank you. Should we then go on with the next session? Chandrika?
Sure, sir. Please do.
Okay. gives me a great pleasure to introduce our next speaker for this morning. Is he online? Dr. Joe Carcillo.
Yes, Praveen, I am.
Hi.
Hi, Praveen.
Good morning for you. Good
Nice
evening
to
for
see you.
us.
Yeah.
Good to see you. It gives me an immense pleasure to introduce Dr. Joe Carcillo. He's a senior pediatric intensive care physician, has been at Pittsburgh Children's Hospital for a long years, as long as I have known of him. He has been a key person in publishing 2002 neonatal and pediatric hemodynamic parameters guidelines. They have been revised several times, 2007, and then finally in 2017. And currently, he is on the task force of redefining pediatric sepsis, the revised pediatric sepsis guideline. Now, in all of this, he has had more than 340 publications in index journals. He is also involved with a precise trial on Anakindra, as well as he's also involved with the GM-CSF. So his talk today is going to be concentrated around ferritin, CRP, other inflammatory markers to really look into what is their impact on mortality, and also emphasize, is this an under-recognized thing in the PICU routine of the intensivist rounds? Dr. Carcillo.
Thank you, Praveen. Will you bring up the slides or should I share my screen?
I think you should. You should.
Okay.
Yeah.
Can you see them?
Yeah, if you could do the slideshow. Yes.
Yep. Okay, great. So Dr. Bhatt asked me to put this slide first. That's me.
Yes.
I apologize if my camera's not working today. It may be to your benefit. We'll see. The title of this talk is I Got the Fever. And we're going to talk about using procalcitonin, C-reactive protein, and ferritin levels to guide therapy in pediatric sepsis. I think I am not going to give the wonderful talks that were given before. My talk is a bit more practical, I think, for you. So this is a child in our ICU who had respiratory Enterobacter pseudomonas infection, had C. diff infection, had peritoneal Enterobacter pseudomonas, a very prolonged course. You see the child had peritoneal drains. The child was treated with Anakindra and with methylprednisone, and with a great deal of management of abscesses. You can see that each day we obtained a ferritin level, a procalcitonin level, a CRP level, and a white blood cell count. Now there are approved for you and available to you in your laboratory tests, 3 tests that we'll concentrate on today. First is procalcitonin. It's made by the Clara cells of the lung. And the higher the level, the more likely you are to have sepsis and more severe sepsis. C-reactive protein was the first pattern recognition receptor identified. It recognizes both the C polysaccharide on bacteria, but also phosphatidylcholine on your host cell. And so it will increase if you have any necrotic cells of your own making, or if you have bacteria. And then ferritin is released by macrophages, as is C-reactive protein. And it is released in 2 factors in response to iron, but also toll-like receptor 9 stimulation by DNA viruses, host mitochondrial DNA viruses, damage-associated molecular patterns, and actually we'll talk about in response to sequential viral and then bacterial infections. I've lost your picture. Can you still hear me?
Yes, we can hear you.
Okay. When ferritins are high, they can be related with iron overload. And patients who have iron overload, it will be related to a transferrin saturation greater than 45% or a total iron binding capacity greater than 40%. But otherwise, if ferritins are high, you can feel fairly confident it's a marker of macrophage activation.
As a blood pressure, so we'll increase in adequates of 2, and we'll make sure that at each peak we give 10 to 15 breath cycles, and then at the end of 10 to 15 breath cycles, we'll perform the.
I request all the participants to please mute yourselves. Thank you.
Okay. In clinical practice, pediatricians use procalcitonin to assess bacterial infection and sepsis risk. And today we'll discuss whether C-reactive protein and ferritin can be used to assess systemic inflammation risk in hospitalized children and to aid in assessing response to therapy. So here are the levels for procalcitonin. Less than 0.1, a bacterial infection is highly unlikely. And there's a strong recommendation against using antibiotics. From 0.1 to less than 0.25, bacterial infection is unlikely, and people still recommend against it, although it's not highly unlikely. But at 0.25 to 0.50, bacterial infection is likely, and antibiotics are recommended. And if it's greater than 0.5, bacterial infection is very likely and strongly recommended. Now, when we think of the cytokine storm, we published about the cytokine storm in 1996 in sepsis. In this simple form, and you're at the bedside and you're trying to figure out if your patient might have a cytokine storm, it's fever. So that's why the title of this talk is I Got the Fever, which is also the name of a popular song as well. So fever is generated by the hypothalamus thermoregulatory center, and specifically in response to interleukin-1 beta. Interleukin-1 beta is released by white cells. And then interleukin-1 beta can affect endothelial cells to make IL-6, and then that in turn can cause the liver to make C-reactive protein. IL-1 beta can also affect the bone marrow directly or through IL-6, and that affects platelet counts. If you inject endotoxin into a volunteer, these markers have a certain time pattern. You can see that the first marker to go up is IL-6. The second marker to go up is procalcitonin, and procalcitonin goes up fairly high. So you can see that if you have a patient who's coming in the first hours of bacterial sepsis, they'll be below levels that are recommended for treating bacterial infection. But if it's after 3 hours, this patient will reach a procalcitonin level that's above the recommended levels. Now, C-reactive protein has a greater delay. So C-reactive protein goes out 6 hours, and when you're looking at C-reactive proteins greater than 1 as a marker, out 12 hours. So that's why it's recommended that you use procalcitonin. Now, if you have IL-6, IL-6 is fine too. But what you'll notice about IL-6 is even in the face of a bacterial infection, or in this case, bacterial antigen, it will return to normal by 24 hours, whereas procalcitonin will remain elevated all the way out to 72 hours. So that's why it's recommended in general terms to use procalcitonin as the best marker, because it goes up early and stays elevated. And then the next marker recommended would be IL-6, but you are unlikely to have that at the bedside. And then the next biomarker would be C-reactive protein, which basically you have to wait for 12 hours before you can expect it to go over the positive diagnostic level. This slide by Dr. Slats, Tenover, Van der Verdonk, and Nadia from Holland shows the evolution or the more recent thought process on how you can use biomarkers at the bedside to distinguish in part between bacterial infection and viral infection. So the bacterial infections we talked about increases IL-1, and that leads to IL-6, and IL-6 leads to CRP. So you can look at procalcitonin or CRP levels. But viral infections, as was pointed out earlier, actually lead to an increase in IL-18 production. And that, in response, increases ferritin. So you can get an indication of a viral infection according to ferritin levels. On the left, you can see that you can actually put together a figure with CRP on the y-axis and ferritin on the x-axis, and it's demonstrated nicely. So you can see the CRP is quite low, and the ferritin goes up from normal to hepatitis C virus, Epstein-Barr virus, HIV virus, and dengue virus. And then when you're looking at bacterial infections, you can see that the ferritins are quite low, but the CRP is higher with bacterial meningitis, sepsis, salmonella enteritis. And pediatric sepsis is rather interesting, just to note, because children, which are the patients I take care of and are taken care of at Rainbow Children's, actually have a bit of a higher ferritin level and a higher C-reactive protein, which is really the topic of this talk. Now, unlike what we heard earlier, where there was a lot of talking about ferritin being related to viral infection and T-cell activation, most of the increase in ferritin that we see in sepsis is actually related to red blood cells. So ferritin will go up because you have been given blood transfusions, or more commonly in our patients, if you have an endotheliopathy, your red blood cells lyse, you may or may not see schistocytes. Free hemoglobin goes up, it attaches to the hemoglobin haptoglobin complex. And this in turn is broken down in the macrophage and results in a release of ferritin. Now, if you're trying to figure out if this process is at play, if you send off a blood gas and you look for carbon monoxide levels, you'll see these patients will have high carbon monoxide levels. And so in sepsis, we commonly see, because of endotheliopathy, low-grade hemolysis, an increased carbon monoxide level, and an increase in serum ferritin. But when you look translationally as well as transcriptionally at what controls ferritin, it's the iron through the iron responsive element, which is A, and B, but it also interacts with TNF alpha and IL-1 alpha. So if TNF and IL-1 are increased, this increases the transcription of iron. And then if you have free iron, this increases the translation of iron. So commonly in sepsis and in the ICUs and in the hospitals with children, you're seeing a combination of the effect of inflammation, but also free hemoglobin. And the type of hemoglobin that is made can either be what's called, the type of ferritin that is made can also be called type 1 or type 2. Now, when you look at this model of inflammation, you can see on the left upper hand corner that hemoglobin, haptoglobin, SCD163 can increase free iron to increase ferritin. And when you look at the upper right-hand corner, you can see that viruses, as well as damage-associated molecular proteins and host DNA, can all stimulate toll-like receptor 9 and activate the inflammasome. The inflammasome can increase interleukin-1 as well as IL-18. IL-18 can stimulate interferon gamma. Interferon gamma, as well as IL-1, can directly increase ferritin levels. Now, what's interesting about ferritin is that ferritin itself will upregulate it in a promiscuous fashion, all toll-like receptors. So there's actually a positive feedback loop that occurs. And in blue, you can see various therapies you can use to block these. So if you have free hemoglobin, you can use plasma exchange therapy. You can also use pentoxyphylline, which will reduce hemolysis and also control TNF levels. For viruses, you can block the viruses with IVIG. For inflammasome activation, you can use glyburide or other small molecules. For IL-18 binding protein. For interferon gamma, you can use anti-interferon gamma. You can use, for lymphocytes, you can use anti-thymocyte globulin, and you heard earlier about etoposide. But the key aspect of things is that ferritin itself actually induces in hyperferritinemic sepsis and MODS both immune suppression and inflammation. So you get the seesaw that was previously reported in the prior lecture of both an immune suppression phenotype and also a hyperinflammation phenotype. Now, we kind of finally understand from this animal model why some patients with sepsis develop hyperferritinemia and hemophagocytosis, and other patients with sepsis do not. And this is amongst the patients who do not have genetic abnormalities. These are normal mice. And in this experiment at the Yale Immunobiology Laboratory at the Howard Hughes Institute, they subjected the mice to different sequences of antigens, bacterial then viral, bacterial then bacterial, bacterial then viral, and then viral and bacterial. And of these, what they found was a distinct pattern of cytokine activation and hemophagocytosis in patients who in mice who were first exposed to viruses and then bacteria. When we look at children in the ICU, co-infection, virus and bacteria infections together are what's related with worse outcomes in pediatric sepsis. You can see in panel A that ferritin levels go up dramatically in the mice who are virally primed and then bacterially infected. And this is true with antigens as well as live cultures compared to all the other sequences. These patients have high triglycerides. They develop high liver injury, low white count in hemoglobin or cytopenias and platelets, a high SCD25, and a high hemophagocytosis. And from Dr. Hender's talk, where he was talking about this as being the HLH-MAS phenotype, he concentrated beautifully on the concept that this is driven by T cells and interferon gamma. But in sepsis, it's the opposite. What it's driven by is by macrophages. And so these investigators, it's macrophage activation. So these investigators, when they gave 2-deoxyglucose, they were able to resolve this phenotype and save the mice. But when they gave interferon gamma antagonists or used interferon gamma knockouts, or they did T cell knockouts, they didn't help these mice. So this model of sequential viral then bacterial infection is not interferon gamma driven, it's not T cell driven, and instead it's macrophage activation driven. And the 2-deoxyglucose, what it does is prevent glycolysis in the macrophages, because the only way that you can have macrophage activation syndrome in sepsis is for the macrophages to metabolically reprogram from oxidative metabolism to glycolytic metabolism. Now, the very important thing as to why we have to be careful with our words of SHLH versus infection-associated HLH versus hyperferritinemic sepsis is that when they treated the other mice who had bacterial, viral, or viral bacteria with 2-deoxyglucose, they actually killed the mice. So there are specific phenotypes that need to be treated differently. You need your macrophage function when it's bacterial followed by bacterial. You need your macrophage function when it's viral then viral. You need your macrophage function when it's bacterial and viral. But when it's viral programming and then bacterial, the macrophage activation itself is deleterious. In this paper, we looked at children with sepsis, and we show that as your maximum ferritin level goes up, the number of circulating DNA viruses goes up. And so higher ferritin levels, specifically over 1,000, are associated with an increase in reactivation of DNA viruses, including EBV, CMV, HSV1, adenovirus, parvovirus, and BK virus. And to some degree, what you're seeing is the combination of DNA viremia driving the ferritin process. Now, the good news is that there is a way to treat this in animal modeling. If you give an animal a CpG as your viral antigen, and then give endotoxin for gram-negative, or you give lipotecoic acid for gram-positive, the macrophages and dendritic cells, again, macrophage-driven, they release inflammatory cytokines, IL-1 beta, and this stimulates with TNF cell death in the hepatocyte. The hepatocyte will make interleukin-1 receptor antagonist protein, which is Anakindra, to block this process. The type 1 interferon gamma, or type 1 interferons, will also block this process and prevent liver injury. So, interleukin-1 receptor antagonist protein and interferon, type 1 interferons, will prevent liver injury and inflammation with this co-infection mechanism in sepsis. And that's shown here. You can see they give the CpG plus LTA, which is virus plus lipotecoic acid. Then they give PEG interferon alpha, and they can improve survival in panel B. I'm sorry, in panel A. And then you can see in panel D, in this model, they pre-treat with Anakindra, and they can then give the virus and the LTA, and this time endotoxin, and they can protect again. So you can have protection in animals. And in this study in 2015 with Dr. Bidashikuri and Dr. Andy Krohn, we contacted Dr. Steve Opel, who had done this pivotal trial looking at Anakindra back in the 1990s. And of note, almost all the DMARDs, or the biologics that are used in rheumatology, actually were first developed in sepsis, and Anakindra was not different. The reason that these anti-inflammatories went from sepsis to rheumatology is they're very effective against pro-inflammatory conditions such as arthritis, but you still have to kill infection. So in this major trial with interleukin-1 receptor antagonist protein, there was no difference in outcome from adults with septic shock. But Dr. Shikuri, after analyzing the data from Dr. Ravelli's consensus criteria for rheumatologic macrophage activation syndrome, found that if you had combined hepatobiliary dysfunction and disseminated intravascular coagulation, the likelihood of meeting Ravelli criteria was 81-fold higher. So we just applied these criteria in a post hoc manner to this randomized controlled trial. And what we found was when you took patients who did not have hepatobiliary dysfunction or DIC, and you treated them with Anakindra or placebo, there was no difference in outcome. The survival probability was approximately 70%. Now, when you look at the survival probability of patients who had hepatobiliary dysfunction, DIC, which represented 6% of septic shock patients, you saw in the dotted, bolded lower line, a survival of only 35%. And when those patients were treated with Anakindra rather than placebo, you could see that you could restore the survival of those patients back to the same level as patients who didn't have macrophage activation syndrome. So unlike the animal model from the Yale University Immunobiology Lab at Howard Hughes Institute, which showed that deoxyglucose or 2-deoxyglucose to inhibit macrophage function killed the animals who did not have the sequential exposure to virus and then bacteria, Anakindra did not kill the patients who did not have hepatobiliary dysfunction in DIC. So it was safe even in the patients without it. But like 2-deoxyglucose, using that as a macrophage inhibitor, using Anakindra as a macrophage inhibitor in this subset of populations improved their survival. And so this was really our first kind of proof of concept that if you go after the macrophage in sepsis-associated or septic shock associated macrophage activation syndrome, defined by hepatobiliary dysfunction in DIC, you can improve outcomes in this group of patients with a very high severity risk. Now, you could actually define these patients based on ferritin levels as well. You saw earlier the varied definitions using ferritin. One was 2,000. And here you can see that when we looked at the whole population in this post hoc analysis, a ferritin greater than 2,000 had 20% less survival than a ferritin that was less than 2,000 in these adult septic shock patients. And when you look at these patients who had a ferritin over 2,000 and then broke down the treatment of Anakindra versus placebo, you can see that this mortality risk was completely reversed. That is to say that Anakindra group's survival was the same as though you didn't have a ferritin greater than 2,000. Now, coming back to Rainbow Children's then, with all that background about CRP and ferritin and procalcitonin, the question is, can I use a contingency table of C-reactive protein and ferritin to identify systemic inflammation mortality risk in hospitalized children, or a cytokine release syndrome that is related to mortality that perhaps I want to intervene in? And this study, which we published in 2019, is from Children's Hospital of Pittsburgh. We first looked at all the patients who had received CRPs and ferritins in our hospital. And then we did a receiver operated characteristics curve with a Unins index. And you can see that the cutoffs that were best at predicting mortality were a ferritin level greater than 373.7 or a C-reactive protein level greater than 7.1. And notice that we use milligrams per deciliter in our hospital for CRP. Now, if you set up a 2x2 table and you call low systemic inflammation risk patients who had a CRP below this threshold, below 7, and a ferritin below this threshold, below 373, you can see these low-risk patients. None of the patients died in the hospital. Only 1 of 100 had died at a year. And their organ dysfunction score, their PUOD score, was relatively low at 6. Now, the next thing we looked at is what if only one of these biomarkers of cytokine storm are up, and meaning CRP's up, but not ferritin, or ferritin's up and not CRP. And you can see that if your CRP was up, but ferritin was not, that your mortality in the hospital was close to 6%, remained 6% a year, and you had developed higher organ failure. Now, if your ferritin alone was up, you saw a mortality rate of 7% at 90 days and a year. So very similar, but clearly higher than 0% when you were below both thresholds. And if you were above both thresholds, your ferritin was over 373 and your CRP was over 7.1, your mortality in the hospital was 21%. And importantly, it went up to 30% at 90 days and a year. And your organ dysfunction score went up to 12, showing you quite nicely that you could, at the bedside, gauge cytokine releasing syndrome or storm and its severity related to mortality risk with 2 very simple tests. In hospitalized patients, not just ICU patients. This is a plot that is called a bag plot. And here, this gives you the advantage of both seeing the CRP and ferritin together in an individual patient. The dark blue represents the 50% with the lowest inflammation, the light blue with more inflammation. Now, the center where you see a gold trapezoid, that is the Tukey median. That is the patient who has the median amount of inflammation, combined CRP and ferritin. And when you look to the right upper quadrant of this bag plot, you can see circles. Each of the circles were death, and you can see quite nicely that all but one of the deaths occurred in the patients who had the highest ferritin and CRP inflammation together, consistent with the 2x2 table. And one of the deaths was associated with a patient who had higher CRP but not ferritin. When you look at the Seattle Children's, just looking at ferritin alone, they show that the risk for requiring ICU care in the hospital or death goes up as you go up above 1,000 to 3,000 and then 3,000. And in fact, using Cox proportional hazards, it's a stepwise risk at 1,000 on up. And still not, this is still well below the 10,000 that people are using for MAS HLH. Now, we do the same thing with children with severe sepsis in the ICU. In this paper, we show that the initial ferritin and the initial CRP are actually more predictive of outcome than the PRISM score, which is the pediatric risk of mortality score that's used. Here, the area under the curve for the PRISM score is 0.67, for CRP it was 0.77, and for ferritin, 0.88. And when we do the 2x2 plot using the same technique as we did in the hospital, we see a very similar finding. Now, the cutoffs are different. The cutoffs in our ICU, rather than being 7 as it is in the hospital for CRP, it was 4. And for ferritin, rather than being 378, it was 2,000. You can see in our ICU that if your CRP and ferritin are below the threshold, there was 0% mortality. We had no patients who had a ferritin over 2,000 and a CRP under 4. But amongst those who had a CRP over 4 and a ferritin less than 2,000, our mortality was 5%. And then this mortality went up to 46% when both CRP and ferritin were elevated. And when we took the patients who had elevated CRP and ferritin, if during their course in the PICU, their CRP and ferritin levels returned to the low inflammation box, they too had 0% mortality, and the mortality of the other boxes went up to 35%. Again, suggesting that if you can get inflammation down, your survival is much better in sepsis. Here's an individual patient. You have ferritin and ex vivo TNF alpha on the left y-axis and CRP on the right axis. This patient had a high C-reactive protein of approximately 30, but a normal ferritin of only 300. As the patient received antibiotics and cleared the infection, the patient's C-reactive protein comes down, the ferritin number goes up. The ex vivo TNF response, which is a response of blood to endotoxin in terms of TNF production as a marker of immune function, goes up, and the patient resolves bacterial pneumonia and septic shock. This patient starts with an elevated CRP and ferritin. The CRP was 23, the ferritin was 3,500. The child had immunoparalysis. It was unable to fight infection based on our ex vivo TNF response to endotoxin. This was a transplant patient. Simply by tapering the immune suppression so that the immune system could recover and using appropriate antibiotics, we see the C-reactive protein and the ferritin normalize as we see the ex vivo TNF response in triangles increasing. There was a secondary infection at 23 days, which is where you see the bump in C-reactive protein again, but that was not viral and then bacterial. So you just saw a bump in C-reactive protein, but not ferritin. And that resolved with new antibiotics and the child lived. In this individual patient who started off with no immune system, the ex vivo TNF response in triangles is actually along the 0 line, had a high C-reactive protein of 28 and a ferritin of 3,600. And you see over the 16 days as immune suppression was not dropped, that the immune depression continues throughout, and you see the CRP and the ferritin continue to rise until death. In this top panel, you see a child who came in with EBV, associated hyperferritinemic multi-organ dysfunction syndrome, which is indistinguishable really from the infection HLH, infection-associated HLH of EBV. You can see the ferritin levels on the y-axis and the hospital day. You can see that we started Anakindra. The ferritin levels came from 1,800 down to 500. The Anakindra was discontinued. The ferritin went back up to 2,000. The Anakindra was continued again down to 500. This patient looked very much like a rheumatologic picture with serositis. We actually had to discharge her in Anakindra, and she was followed for a year at the NIH. They never could understand why she had this syndrome, but it took them an entire year to wean her off Anakindra. This was, however, virally induced. Below this is a patient who was 3-year-old who had adenovirus induced hyperferritinemic multiple organ failure syndrome. This was during the adenovirus 17 outbreak. On the y-axis, on the left, you see ferritin. On the right, you see adenovirus levels, and you see hospital days. This patient was required extracorporeal membrane oxygen support. You can see we started Anakindra, and there was no drop in the adenovirus levels, PCR levels, but there was a minimal effect in ferritin. It wasn't until we started Cytophavir on day 8 to treat the adenovirus that we saw the drop in adenoviral PCR, as well as the drop in ferritin levels. And then you see a spike in the ferritin levels, but not in the adenovirus PCR. That's because there was a perforation of the heart with a lot of blood transfusion on ECMO circuit. That blood increases the ferritin levels. We perform plasma exchange to remove the free hemoglobin, and you see the ferritin come down again. And then you see over time that the adenovirus DNA PCR titer normalized, as did the ferritin. So treatment not only of inflammation with Anakindra, but also treatment of the viral infection. And so this brings us back to our initial patient, and you can see, I'm not going to take you through each of these factors, but you can see that by looking at CRP and ferritin as markers of your cytokine storm, IL-1, IL-6, bacterial related, and then viral or free hemoglobin related with ferritin, and then responding appropriately, you can control inflammation. And then looking at procalcitonin, you can use that as a biomarker for good source control. Remember, you've had 2 other beautiful talks, one on ferritin and one on COVID-19. But remember, there are other syndromes that are related to free hemoglobin, such as Ebola hemorrhagic fever, where ferritin levels, again, are related to sepsis, but also free hemoglobin. Dengue, which you had a very beautiful talk on, and COVID-19, which you had a beautiful talk on as well. In all cases, remember to look at procalcitonin levels, and if they're high, you need to really consider antibiotics, although clearly it may not be a live bacteria because it could be just endotoxin leaking, but we really don't want to take the chance when we have critically ill patients. So if your procalcitonin is high, bacterial or fungal infection, treat with antibiotics and antifungals. If your ferritin's high, see if it's iron overload and consider treating with desfluranox. If it's not iron overload, it's macrophage activation, treat with methylprednisone and IVIG. And if you can look at PCRs, you can use more specific treatments for virals. And if you have high C-reactive protein, think heavily about tissue necrosis, bacterial infection, or lymphoma, because the B cells from lymphoma stimulate IL-6 production and C-reactive protein production as well. Your ultimate goal in managing cytokine releasing syndrome using this CRP and ferritin contingency table is to have your patients go from high risk to low risk, intermediate risk to low risk, intermediate risk to low risk. Thank you very much.
Thank you, Joe, for giving an excellent talk. Basically, since you have emphasized so much on ferritin and C-reactive protein and the values, and I've shown that the mortality changes. Does that also apply to viral sepsis, or just this is a combination of viral and bacterial sepsis in children?
It also applies to viral sepsis.
Yes.
So,
okay.
So
okay.
Going back to this, can you see my slides?
Yes. Yes.
Yeah. So these patients here had only viral sepsis.
Right.
The patient at the top had EBV. The patient below had adenovirus.
Adenovirus. Right.
Their procalcitonins were normal. They didn't have bacterial infections.
Right.
This patient here had bacterial and viral infection.
Right.
This patient only had a bacterial infection. You see the ferritins weren't high.
Right.
So it applies to all patients. And why might that be? Well, when you look at SARS-CoV-2, it's a viral infection. 71% of MIS-C patients have procalcitonins of 12 or higher.
True.
You cannot distinguish whether that's endotoxin leaking from the gut or that's live bacteria. And in the paper by Texas Children's Hospital, they had 100% survival in their MIS-C patients despite 2 needing an Impella and 2 needing ECMO. And over 70% of their patients were being treated for bacterial infection. So it's not only live bacteria infections. Let me show you this again. When you look at this effect can be seen if you use the antigen of the bacteria or live bacteria. This effect can be seen if you use viruses taken directly off of tissue culture, or you just use the mimickers, like in this case, IC, which is a mimicker of RNA virus like COVID. So
yeah.
What it does, the CRP and ferritin, quite nicely, is if your procalcitonin is normal, you don't need to treat with antibiotics. But if your ferritin's high, you have to say, okay, what virus does this patient have?
Right.
And does the patient have free hemoglobin?
Now, one question that's been brought out by Dr. Deepika, can we have high PCT even in CRS without bacterial or fungal infections like we have in COVID?
The answer is, again, the question is live or dead. So procalcitonin just tells you that you have high circulating levels of live bacteria or dead bacteria.
And then what about the SJIA and MAS? If
procalcitonin is elevated, it means you either have live bacteria, at a high level, like it is with SARS-CoV-2 at say 12 in ICU patients with MIS-C, or with COVID-19 patients, adult patients. When you look at deaths in adult patients, they're all almost always from bacterial and fungal infection, not from the virus alone.
Right.
And so if you see a high procalcitonin, that tells you have live or dead bacteria. If you decide that it's dead bacteria, that's fine. But we treat it as though it's live bacteria. And what we see, which I didn't show you, but other papers that we published, is that Procalcitonin going up shows that you're not killing the bacteria and you die. So if you're a sepsis patient and the procalcitonin continues to go up, your patient dies. If you treat the bacteria or remove the nidus, your procalcitonin goes down, your patient lives. So procalcitonin is really what we have that's best. Septicite is a new test, but it's only approved for adults. So right now we just have procalcitonin as the best.
Okay. Well, thank you, Joe, for that lucid talk. And I'm sure there are going to be many more questions, but in the interest of time, we will go on with our case.
My pleasure. Thank you for having me.
Thank you. Thank you. Yes. So, Chandrika, all yours.
Thank you, sir. So with this, we'll move on to the case discussion. I invite Dr. Akshay Shetty and Dr. Ibor Jacob, who will be the moderators for the next session, and also our mentors, Dr. Joe Carcillo and Dr. Ramanan, to join us, please.
All right, so thank you very much for wonderful talks for the session 1 and session 2 of day 1. So we'll end up with a case discussion. So the case what we have chosen today to end the day is sepsis-related HLH. And I would request a team from Christian Medical College, Vellore, to present the case. I would request Dr. Ibo Jacobs, a dear friend of mine, who is a head of pediatric intensive care services at CMS Vellore, to introduce his colleague who will be presenting a case of sepsis HLH today.
Thank you. Thank you, Akshay and Dr. Chandrika, for inviting us to present the case. Without much wasting the time, this patient was managed in our PICU, was managed initially in a peripheral hospital in Andhra Pradesh and referred to us. And we had a challenging time in managing this child with multidisciplinary team involvement. And unfortunately, we lost this child. And we'll have Dr. Sanket, our assistant professor from our team in pediatric ICU at CMC Vellore. He's going to present, and we'll throw in between questions to our experts. Over to you, Sanket.
So meanwhile, before Sanket loads his presentation, like just Dr. Ibor said, we'll stop Sanket in between to generate some amount of discussions and based on the case story, and we'll be asking it to Dr. Ramanan and Dr. Joe Carcillo. Meanwhile, if the audience have any questions, do post to the chat box. If time is there and if it is feasible, we'll take up those questions. Over to you, Dr. Sanket.
Thank you. Good evening, everyone. I'll be presenting a case which we managed recently. And I think, as Sir said, the expert can give their opinion on between the questions. So this is a 3.5-year-old male child who presented to us with complaints of fever for a month, abdominal distension for 2 weeks, and jaundice for a week. So coming to his past history, there's no significant past history. Antenatal history, he is a second-born child to a second-degree consanguineous parents. Previously, he had 4 abortions in the first trimester. He has an elder sibling who is 5-year-old, who was born through in vitro fertilization. And this child was born through LSCS because previous LSCS was there. There was no significant birth history, and he is a developmentally normal child. So, course in the previous hospital, before he came to us, he was treated in the previous hospital, in a private hospital for a month, for around 25 days. So initially, for the first 6 days, he was treated on OPD basis for the complaints of fever for 3 days with some oral antibiotics. So on investigation, they found vital was positive with a ratio 1:160, for which he was given oral antibiotics. Because his fever spikes didn't subside, he was admitted and evaluated, and he was started with empirical antibiotics of Miro and Doxy. And because it being a pandemic, they have evaluated for MISC also, and they found COVID antibodies are positive. And his echo was showing dilated coronaries, for which he was treated with IVIG 2 grams per kg and methylprednisolone, for which the dose we didn't have. Subsequently, he was simultaneously worked up for other infection also, like Vidal, Felix, Dengue, which all were negative, and his 3 blood cultures were also sterile. Because his fever spikes were persisting and he had bicytopenia with some cholestasis, he was worked up for malignancy, Hlh, and immunodeficiency also. Malignancy wise, PET scan was done that was showing some increased uptake in the colon, for which biopsy was done, which showed some reactive changes. And this biomarkers, serological markers that was done for Crohn's disease and inflammatory and other inflammatory bowel disease was also weakly positive. So it was not treated adequately. And then HLH workup wise, he had bicytopenia and ferritin of 250, for which he was fitting into the criteria. So they have given him a second dose of IVIG there. And this primary immunodeficiency workup was also negative. But because his fever spikes were persisting, they had sent a culture that had grown. He had an IJV that was put there, but date was not available. But that culture had grown Klebsiella, for which they have upgraded the antibiotics and they have added colistin also. And because his fever spikes was persisting and they didn't have a proper diagnosis, they referred the child to a higher center. So that is when, after day 26, he came to us. And here in pediatric casualty, he was found to be in compensated shock, for which one fluid bolus was given. It was connected to high flow oxygen and antibiotics were started empirically with Miro, Tico, and Doxy. Fluconazole also we started. He came to us, he was having neutropenia and thrombocytopenia was also there. Around HB was around 8.6 and the total counts was 300, neutrophils were 0 and platelet counts around 30,000. Because in view of persisting fever spikes, we are also worked up for this infective workup. Blood cultures were sent, another infective workup was also sent. Blood culture had grown Klebsiella. We started with Mirodoxy and then we added Klebsiella. We added colistin because it was a CRO. And we had also worked up for HLH, and that suggested he had fever spikes. Bicytopenia was there and splenomegaly was there and his ferritin was 1500. Soluble CD25 we had sent, that was abated. We continued steroids because he received methyl-pred there. We don't know how many days and how much he received. So we just continued this hydrocortisone 100 mg per meter square in 4 divided doses we continued. And MISC workup wise, we had done an echo also that showed dilated coronaries. Otherwise, he had an NT-proBNP of 596 and D-range bleeding parameters also with D-dimer of 8700. And he had a right IJV and the local site swelling was there with pus was there. So we have removed the IJV and the pus was aspirated and sent for culture. And other autoimmune workup were all negative and viral infective workup was also negative. So this is the initial management we did when this child was in emergency and in HTO.
Okay, so the question to Dr. Ramanan and to Dr. Joe Carcillo is that we had quite a bit of discussion about ferritin and its relevance. So in this particular child, the initial ferritin level was 1500. Does that reflect an evolving HLH or is it just an acute phase reactant? So any thoughts on that?
Yeah, my thought is that your management has been beautiful. Are you saying that this child has consanguinity?
Yes, I think they had a second degree consanguinity.
Yeah, so this child has a profound primary immune deficiency, right?
Mm-hmm.
So this is a child who has an immune system that doesn't work. Because you've had, as far as I can see, it looks like you've had gram-negative infections. You have, with the galactomannan being positive, you have, that's telling you have aspergillus or a fungal infection as well. I would be thinking of something like SCID, severe combined immune deficiency or common variable immune deficiency. And in those, you can clearly get a virus and then a bacteria that could give you the high ferritin you saw. The child also has clearly has dilated coronary arteries. Was the child PCR positive for COVID or only antibody positive?
Antibodies are positive.
Okay, so the child also is having a inflammatory response to COVID with dilated coronary arteries. So I think you have a child who has a severe primary immune deficiency. The fact that you're seeing multiple bacterial infections steers me away from primary HLH. So you're not seeing a primary central nervous system effect. And you're seeing multiple bacterial infections and fungal infections before you ever see a viral infection. So I'm thinking that he has a primary immune deficiency. And that the 15, unless he has an infected line, because you aspirated pus from his line, right? So unless you think these infections had to do with infected lines, that would be different. But I'm assuming that's not what you think, right?
Yeah.
So I'm thinking right now, primary immune deficiency. And the ferritin is not an acute phase reactant. It's telling that you have viral or hemoglobin or free hemoglobin, or there's some other intracellular organism like leishmaniasis, or here we get histoplasmosis, other babesiosis, other kind of intracellular organisms. But with the history of having multiple bacterial and fungal infection, this is a very, very primary immune deficiency affected patients. The dilated coronary arteries, if those are real, you have to figure out if you're really confident in this, because these can be overcalled. But if you're really sure about that, then this is telling you the child has a vasculitis as well associated with this. That's related in the dilated coronary arteries. And then they say, in the face of immune deficiency, can the expression of inflammatory markers change? Yes. The inflammatory markers are showing you what infections are occurring.
So to add to those, specifically to the three questions, since Dr. Carcillo has touched on broad aspects, I would say that the ferritin of 1,500 is more in keeping with evolving HLH and less in keeping with an acute phase reactant. Evolving HLH in the context of what is the big question? Is it evolving HLH because of an underlying immunodeficiency, or is it just sepsis driven? And that remains unanswered with the information you've given. Dilated coronaries, I think I'd be brave enough to hazard that they're more likely an overcall. They are now increasingly overcalled by anxious cardiologists in young children particularly, and a bit of brightness is interpreted as dilated coronaries. And there is a misconception that somehow all dilated coronaries are Kawasaki. And I think, as someone's highlighting, the Z score is more important than just a bit of bright coronaries. And we see this often. A junior cardiology trainee doing an echo, saying there's bright coronaries, reporting as dilated coronaries, only for somebody more experienced to come and say that there is no aneurysmal dilatation. And what we don't know is, and if we go around echoing lots of febrile children, you might see this brightness, which is being reported as dilated. So I'd be dubious in assuming this is actual dilated coronaries if there is no aneurysmal dilatation. And in the face of immunodeficiency, can the expression change? Yes, and it seems unusual to have so many bacterial and fungal infections, but I do know that so much has been done outside, and I know the context sometimes of interpretation in tertiary settings in places like Vellore, when you have patients come after protracted periods elsewhere, makes your life even harder than what we face when we have a fairly more virgin population. We can decipher exactly what's happened, whereas you have a lot of unanswered questions on what exactly was the therapy that they got locally, how much steroids. So you don't know if some of these is because of excessive amounts of steroids given as well. So I think I will, that would be my answer, mostly echoing what Dr. Carcillo said, but I have to see how he's evolved with you.
Was there any infection before Sanket? Was this child affected anyone?
Yes, sir. He had like blood Klebsiella.
Okay. So we have sent a primary HLH genetic workup at that time.
Yeah, I think primary HLH would be unlikely in this patient, because the patient, from what I'm reading, you had hepatosplenomegaly of long-standing significance, and you only had a ferritin of 250. I find that very kind of unusual in primary HLH. Now, part of this is semantics. I use hyperferritinemic sepsis. I'm still waiting for the HLH MAS community to tell me what the clear cutoff is of ferritin. So my understanding from the McLean work was that over 10,000 is what is used to suggest that it's HLH. And this child was 250 at the beginning, and now it's 1,500, which is why I'm thinking it's more that you now have viral reactivation, or a new virus that's interacting with your bacterial infection.
So it sounds like they've done a basic immunodeficiency workup before referral. So the immunoglobulin levels were normal, and the lymphocyte subsets were slightly on the lower side before the child was referred. So that was the immunodeficiency workup they had done before the child was referred. Right? So let's go ahead, Dr. Sanket. Okay. There are a few more questions in the journey. We can probably try to address some of them.
Sanket?
So then child was
I don't see any
ICU on day 4 of
I don't see any
where when he
Sanket, can you do it full screen?
Tachycardia
Can you do it full
because he
screen,
had
Sanket?
no diastolics also. He had to start.
Sanket, we can't hear you, and your slides are stuck.
I'll share it, Sanket, or
while we're getting the slides to work, I didn't see any procalcitonins. Does your hospital do procalcitonin?
Yeah, we do, but
Okay.
in this particular patient, I don't think procalcitonin was done.
it was done later. It was
done later.
200. It was
Okay.
very high.
Okay. Okay.
Okay, we can see the slides now. Do you want to present, Sanket?
So on day 4 of illness.
Can you go back? Yeah. Go back?
Yes, sir, I'll go ahead. So on day 4 of illness, because he had
I think your voice is breaking up.
Sanket, you press and I'll share the screen, or
I think his voice is also breaking up. Might be one of us
No,
can
sir.
just present the case. Then.
are able to see the screen, Sanket?
Yeah, we can see the slides, yes.
Sanket, are you there?
Or maybe we can
Yes, sir,
just...
I can, yes.
Okay, next slide.
Okay, so we have done this and we have gone to these questions. And now day 4. Yes, Sanket. Okay, so this day 4
Yes,
in PICU,
so
this child is
on day
continuing
4,
to have a
because
central...
he had hypotension.
Go ahead.
Yes, sir. On day 4, he had hypotension, so we had taken him into ICU. You can see, you can hear me, sir.
We can hear you. Go ahead, Sanket.
Yeah, you can go ahead.
Yes, so we had continuous test dose steroids, and by the time we had received the report of this blood cultures.
This Klebsiella pneumoniae with the carboxylated of NDM and oxa has grown. Hello, Sanket.
I think it's
Yes,
better. Probably you present it. I think we can.
Yeah, I'll just go to that. So day 4 in ICU, he had some hypotension. That means a white pulse pressure with a low diastolic BP. Noradrenaline was started, and echo showed again some dilated coronaries, but the functions are good. By the time we got his blood cultures and this Klebsiella CRO, and with the sequencing of carboxylated NDM and oxa detected. So ceftazidime, avibactam, and aztreonam was added. And while we are waiting for the other reports, and then by the time with the suggestion of the team, we had done a bone marrow as well, which is suggestive of hemophagocytosis. And this day, that's child showed progressive worsening in the form of encephalopathy and worsening shock, and needed more vasoactive agents. And we have to intubate this child. We can see the worsening of total bilirubin and direct bilirubin. You can see from 14 to 4.84, 4.94, then steadily is going up. But you can see the AST/ALT being low. So he was intubated and ventilated, titrated vasoactive agents. 3 agents were there. And this child showed persistent fluid retention as well as acidosis. We initiated continuous renal replacement therapy. And this time we instituted pulse therapy with 10 mg per kg. Now to the experts. Is there a relevance of bone marrow hemophagocytosis? It's needed at all. So here we have done one which is suggestive of hemophagocytosis. When the child is critically ill, it might be very difficult. And we would like our experts to comment on that. Hello.
Good. So,
sorry, I spoke with you. Carry on, Joe. I was speaking while I was on mute. Apologies.
No, you go first. I went first last time.
Okay, so well, the relevance of marrow hemophagocytosis is overstated actually, and you're right. Many a time it's not possible in critically ill patients to do a marrow. And even in primary HLH, Yaninge's group showed at autopsy, evidence of hemophagocytosis in the marrow was seen only in 33%. Liver and spleen have the best uptakes, but who's going to be brave enough to marrow a biopsy, a liver or a spleen in a very ill child? So your question, is it needed? Not really. Negative hemophagocytosis on a marrow does not exclude the diagnosis. And you can sometimes see 1 to 3% hemophagocytosis in lots of marrows, which doesn't necessarily indicate that it's got an HLH. So I think it can corroborate the diagnosis, but it can't seek the diagnosis. It can't make the diagnosis. So its value is questionable. Hanging everything on it is not justified. Second question is probably something which Dr. Carcillo has published a lot on. So I might defer to him on answering that one.
The bilirubin being high and with the liver enzymes being normalized. So can we take it, how to interpret it in this context?
So the question to Dr. Joe Carcillo is, so does this actually fit into the definition of hepatobiliary dysfunction you see with sepsis? So does this amount to sequential multi-organ failure, what you have described, and where you showed Anakindra to be beneficial? So what are your thoughts on this particular progression with regards to rising bilirubin levels?
Great, thanks. I'll start at the beginning. So there was one that came across about, do you do procalcitonins even when you have a positive blood culture? And the answer is yes. And the reason this patient's dying is that when you look at your sensitivity pattern, the organism is resistant to all your antibiotics. So you have a highly multiple drug resistant organism. And unless you can find some antibiotic that it's sensitive to and also find the source and remove it, the patient's going to die. And as the patient is dying, the inflammatory markers will go up. Now, the question about, and the procalcitonin would tell you that, because if you were getting that each day, you would be able to tell before you got your sensitivity that you're not on the right antibiotic, okay? Because it would keep going up. Now, the bone marrow hemophagocytosis, all patients who die of sepsis on autopsy will show hemophagocytosis. So hemophagocytosis, it's called histiocytic hyperplasia, is seen in all patients who die with sepsis, blood transfusions, and multiple organ failure. So you don't need the biopsy for that. In terms of SMOF is sequential multiple organ failure. You start with respiratory, and then 7 days later, you develop hepatic failure. This patient isn't developing hepatic failure. This patient has a rising bilirubin with a normal OTPT. That is called cholestasis. That is sepsis-induced cholestasis. So the patient is showing you unremitting sepsis due to a multiple drug-resistant organism.
Thank you so much, Joseph Carcillo and Ramanan. Let's move ahead.
Sanket, are you there?
Yes, sir.
Okay, go ahead.
So this is the course in our PIC what we did.
So on day 4, because he had gone into septic shock and hypotension, we have upgraded the antibiotics. And then he's after on day 5, his sensorium dropped. So we had to intubate and ventilate him. And then he was in inotropic requirement has also gone up. He was in 3 inotropes, adrenaline and vasopressin. And CRP has also gone up from 200 to 300. So we started CRRT here, and these are the cytokine markers that has been seen on the screen. The IL-6 was 1,338, and CD25 had come by this time, just 22,500, and ferritin had gone up from 1,600, it had gone up to 22,000, and CRP is 330. So he had developed AKI, and his liver enzymes OTPT has also gone up by this time, and he was in DIC. So he had gone into multi-organ dysfunction also. So we did 2 sessions of plasma exchange also here, because he had a thrombocytopenia associated multi-organ dysfunction was there. We had done 2 sessions of plasmapheresis, and by day 8 we had got this drug injection, Anakindra we got. So we had given 2 doses of 5 mg per kg in 2 divided doses we have given. And in spite of which, day 9 he had refractory shock and he died of multi-organ dysfunction.
Next. Yes, so the question, the great difficulty for us, I think Dr. Joseph Carcillo and Dr. Ramanan, is that, like you see, we've had an organism which is completely drug resistant. At one end, you are under pressure to start immunomodulation in the phase of developing HLH. And other end, you're not really sure whether you have covered the organism with an adequate antibiotics. How do we approach in such a case? What would your approach be in such kind of circumstances?
Dr. Ramanan first or me first? What do you want?
No, I'm happy with either approach. You go first if you so choose, please.
Please, Dr. Ramanan, you first.
Okay. Well, how would I approach immunomodulation? I think what you face is an extremely challenging situation, and I can only feel for you, and I wouldn't want to be in that shoes. But ideally, you'd want to give an appropriately sensitive antibiotic to treat the infection. But simultaneously, if you have uncontrolled secondary inflammation from the underlying bacteria, the work that Dr. Carcillo alluded to of the use of an agent like Anakindra in proven sepsis makes me reassured in wanting to institute it at an early stage. At the time you commented on the hepatobiliary dysfunction, I would have liked to see the ferritin, which you now point out has been serially going up. So in light of the high soluble CD25, high ferritin, and the bicytopenia, I wouldn't have an hesitation in introducing an agent such as Anakindra. And you've given 5 milligrams IV times 2 doses, but we probably give 2 to 4 milligrams per kilogram per dose twice a day. So and can sometimes go up to 8 to 10 milligrams. But this is an unenviable situation, really.
But we have difficulty in getting Anakindra, Dr. Ramanan.
I understand that.
So just suggest pulse methyl prednisolone we should have given earlier, you think? Or is there any role for IL-6 inhibitors?
I personally don't think there's a role for IL-6 inhibitors, because I think tocilizumab, and I'll extrapolate, tocilizumab in our experience, even in the patients who are on tocilizumab for rheumatological indications, we know that they also get macrophage activation syndrome. And in the randomized control trials, the incidence of macrophage activation syndrome in systemic JIA patients on tocilizumab was not too dissimilar to the control. So, and we know certainly that secondary bacterial infections is a real risk with tocilizumab therapy in pediatric and adult rheumatic diseases. So it hasn't got, in my opinion, at least the same safety profile as Anakindra in the face of proven sepsis. So I'd be loath to do that. Sure. Over to Dr. Carcillo for his thoughts.
Sure. So was the organism sensitive to any of the antibiotics you finally came upon?
So I think they finally got a sensitivity based on the resistance pattern. I think they've just started antibiotics. Dr. Ibor, do you want to just answer this?
Yeah. So we have got the Klebsiella with the carbohydrate NDM oxide detected. Based on that, we have covered with ceftazidime and avibactam and aztreonam.
No, but I'm asking, was the organism sensitive to any of these antibiotics that you finally came upon?
And do we have a final culture report of the sensitivity pattern is, I think, what is trying to...
Yes, sir.
Because the first thing I want to tell you is if you have an organism disseminated through your body that you cannot kill, you cannot live.
This is a resistant organism, but with the synergies we've been seeing, so as per the IDs in consult, we have given the ceftazidime avibactam with the aztreonam combination.
Okay, so but do you know if the so you're saying that the organism was sensitive to that? Because all I'm...
Yeah, probably.
So you think that...
Probably.
I think what they're saying, Dr. Karsile, is that this might be a multi-drug resistant bacteria with a hope and a prayer, multi-drug resistant bacteria, hope and a prayer that it might work on this synergistic combination, but that's more in hope rather than in absolute solid evidence.
Yeah, so I think the first thing for my colleagues to understand is that you have to have a germ that you can kill before thinking about the immunomodulation question, okay? So it's very possible that this is an organism that you just cannot survive. But let's say that you were able to kill the organism, okay, with the antibiotics. Then you did everything we would have done. The only other thing that we would have done, though, is used GM-CSF. So was the patient lymphopenic when he continued to have persistent infections?
GM-CSF was not given. I think they give 1 or 2 doses of Buffy.
Right, but I'm asking, what? So the way
lymphocyte count, is that what is Dr. Karsile asking?
Yes.
What is lymphocyte count?
Lymphocyte count. Sangeet, do you remember?
Yes, sir, it was 0.
0. Okay. Yeah. So if your lymphocyte count is 0, then that's what the patient's problem is that the patient has no immune system to fight the infection. So not only is it an infection that antibiotics may not be able to kill, but he doesn't have an immune system to fight it. Now, we use GM-CSF, granulocyte macrophage colony stimulating factor. Do you have that drug?
Yes.
Okay. We use it at half the dose that is used by hematologist oncologists to recover the bone marrow. We do it for 7 days. If we go IV, we give it over no faster than 12 hours, or we give it subcutaneous. And we do this to restore the lymphocyte count and to reverse anergy. So this child with 0 lymphocytes and an organism that's not sensitive to antibiotics, I don't believe the outcome could be any better than what you had. So I don't think you missed anything. I don't think this is an HLH that would be responsive to the topicide, but we don't have Dr. Henter on the call, right?
I doubt it, but Yanninge would make a case that if you can treat the bug with an appropriate antibiotic, which we haven't been able to, which is the real stumbling block, then he would make a case that there's a role for etoposide after Anakindra. But I really think
Would you say that if there was 0 lymphocytes?
No, I doubt it. I mean, I can't speak for him, but the point is we both, I think if I understood you right, agree that the key issue here is multi-drug resistant Klebsiella, which probably we are unable to come up with an antibiotic which it's sensitive to. And in which case, would early Anakindra, it's highly speculative because we all agree that the primary goal is to treat the underlying bacteremia with an appropriate antibiotic.
Right.
Just a quick question, Dr. Karsile. I mean, you mentioned about GM-CSF. In the phase of macrophage activation, as we've noticed in the presence of HLH, is it safe to use GM-CSF?
So we're doing a trial right now, which is called a PRECISE trial, which Praveen mentioned. We're taking 1,000 children with sepsis, and then we're doing the whole blood ex vivo TNF response to LPS. If it's less than 200, that means you're immunoparalyzed. And if your ferritin level is less than 2,000 in those patients, we're going to randomize them to GM-CSF versus placebo. And this child was earlier in the discussion when the multiple organ failure started, the child's ferritin level was 1,500. And so, or 250, then 1,500. And so if that child was immune paralyzed with our test, would have been randomized to GM-CSF versus placebo. Now, if instead the child's ferritin level is over 2,000, but under 10,000, they then get randomized to Anakindra versus placebo. And if the ferritin's over 10,000 at enrollment, we just observe them. We defer to the Histocytosis Society, calling that MAS Hlh, and don't put them in the trial. Now, so you know in terms of the relative numbers, in sepsis, about 3%, pediatric sepsis, 3% of the patients have a ferritin over 10,000. 40% have immune paralysis. And if we use the definition of a ferritin over 500, 30% have a ferritin over 500. So we're not talking about small numbers of patients, they're large numbers of patients. If we're going to call HLH-MAS a rare occurrence, it is rare to have it over 10,000, which would be HLH-MAS. So we would have treated in our practice outside of this protocol. I would have seen this patient. I would say this kid has primary immune deficiency. If the procalcitonins are going up every day, we're not on the right antibiotic. And I would have said with the lymphopenia, I would have started him on GM-CSF as soon as I saw him. If he came in and his ferritin was high, I would have started the Anakindra right away. Our hematologist oncologists will not give a topicide to a patient who has active bacterial sepsis, like bacteria in the blood sepsis. They just call it hyperferritinemic sepsis. We would have done everything else you did. The plasma exchange we would do for TAMOF, as you did, and it works exquisitely well. What happened for you when you did the exchange? Did the kid tolerate it well?
Sorry?
Did the child like plasma exchange? Did the child tolerate it?
Yeah, we did 2 sessions of plasma exchange, but we could do with a low volume because of hemodynamic instability.
Yeah, he was too sick. Yeah, too sick. Yeah. We also, we do not have survivors. We do not have survivors with carbapenemase resistant organisms and hyperferritinemic sepsis in mods. So if someone said to me out of compassion, they wanted to try Dr. Henter's approach, I wouldn't say no. I would say fine. And if it works, then I say that's amazing. But this I believe is macrophage-driven disease in a child who has a primary immune deficiency and a multiple drug-resistant organism that you can't clear.
So just to add to that, what I would have done is most of what Dr. Karsala says, but we don't use GM-CSF. I certainly would not consider giving it topside, even though I'm comfortable with it in someone with an active bacterial sepsis, but will probably initiate IL-1 inhibitor early. The ferritin debate's an interesting one. So you have the Histiocyte Society, of which I was a part of, and I'm still peripherally. They have a criteria for primary HLH, which was never intended to be used in the context outside primary HLH. So, which is why the ferritin values there are really not appropriate, as pointed out, because a significant number of patients in a significant number of inflammatory settings would meet a ferritin more than 500. So we all recognize it needs to be much higher. Whether it's 5 or 10,000 is a pivotal point. But at some point when it gets into a couple of thousand, I would initiate IV Anakindra, and I would initiate it as IV rather than subcut. But in this child, I don't think you would have had any, it would have been hard pressed in any setting to have an outcome other than the unfortunate one you've had because of the drug resistant bacterial sepsis.
So that's very useful. I think before we're almost coming to the end of the discussion of this case. So just a quick question with regards to various extracorporeal blood purification methods, like there's a cytosorb and there are polymyxin B integrated filters. any role for them? I mean, do they have any additional benefit compared to drugs like Anakindra in terms of removing PAMPs and DAMPs from the system? Let's imagine if this patient was being adequately treated with the correct antibiotic and was immunocompetent too. Would you be considering extracorporeal blood purification method at any point in time, especially because side is on CRRT?
I wouldn't. For me, early onset of Anakindra is much my preferred course rather than plasma exchange and extracorporeal blood purification, because I think they have a role in certain vascular disease where we believe there is a pathogenic autoantibody. Just to leach the blood of circulating cytokines, I think there's better ways of doing it.
Oh, you said early. How early you will start give the Anakindra, Dr. Ramanan?
Well, that's an interesting question. A lot depends on the evolution of the different markers. And I think here you were starting at a highly disadvantageous position of having already had a patient come to you with 20 days of multiple therapies, which is what I expressed, a situation we don't where you're already starting with a massive disadvantage. And so it depends to me, I would have to put the context of bicytopenia and appropriately an antibiotic for a bacterial infection for which I know the sensitivities. And if the patient's not getting better, I'd be brave enough then to start with Anakindra.
Okay. So the best data is out of Japan on the question that you have. And whether or not that's related to genetics, I don't know. Do you have any Japanese on your panel for this conference?
No, we don't have any from Japan.
Okay, they have the most experience with the polymyxin columns. The only studies that have been published in children are like case series of 5, but it did seem to work well with gram-negative. So this was a Klebsiella. So I think it would have been fine if you had a PMA, a polymyxin column cartridge to just put it on your CRT and see what it did for you. But again, it doesn't remove the bacterial infection, you would have to have an organism that you're able to kill. But I think it would have been fine to add a polymyxin column to this CRT circuit because you have proven gram-negative infection, and polymyxin will absorb the endotoxin from the organism.
Thank you.
The trial on the Cytozorb was rather disappointing, I think. So I think if you wanted, it has to do with, like, do you do clinical trials at your center?
Yeah.
Then what I would do is I would do like a phase 1B trial where you'd say to the parents, your child is in this circumstance. We're happy. If this is a therapy that's been approved, if you would like it, we want to establish a safety profile. I would do it as a study in your center, not just because it was a negative trial, the Cytozorb. But as far as the polymyxin, it's been positive in patients with gram-negative infections, so that would have been fine.
I think most of the studies too were probably with intra-abdominal sepsis, and I think they were an adult patient group. So, not sure if there are any pediatric studies to show that it was beneficial in.
Yeah, they're just a case series of 5 or 10. I wrote editorials on them, but it's enough that you could show it to a parent and say, "Here, these doctors in Japan use this, and it's been effective. Do you want us to use it?" But you can do it without doing a trial. But I think the Cytozorb, I would, want to go through your IRB and do a trial on because it's not been shown to be beneficial.
All right. So thank you very much. Do you have anything to Tibor? Shall we?
That's it. I think any other questions from the panel or from audience?
Yeah. I think most of this kind of questions we've kind of discussed during this meeting. So I really thank Dr. Joe Carcillo and Dr. Ramanan for taking their time and going through this case scenario and giving their valuable inputs. And I think what came out of this panel discussion was that the importance of source control, because unless we control the source, just controlling the inflammation might not give us a desired input. So I think aggressive search for the source control, ensuring that we give a correct antibiotic cover, and then having a targeted therapy with the form of Anakindra if it is available, or other options, including possibility of IVIG, steroids, plasmapheresis, when it is done in the context of an infection which can be treated, seems like if done in a timely fashion can have a good outcome. So with that, I just wind up today's session, our day one of cytokine release syndrome conference. And tomorrow we're going to start it again at the same time at around 6:30. We again have interesting talks, and there were lots of questions in the chat box. And I really hope all of you do join us back tomorrow, because a lot of those questions which have been asked are going to be covered in the next couple of days. And all next 2 days too, we're going to have interesting talks, great speakers, and again we'll be ending up with the case discussion. So thank you very much for all the active participation. It's been a wonderful meeting, and we all appreciate, including all the international faculty, being here and giving their valuable input. And if you can also join us for next couple of days and share your insights, because these, as you know, are conditions which probably no one can answer with absolute certainty. And the collective wisdoms can actually help us quite a lot in managing some of these difficult situations. With that, I wind up today's session. Over to Dr. Chandrika.
Thank you for the honor.
Thank you.
Thank you, everyone. So we'll end today's session. And as Dr. Akshay said, we'll see you all again tomorrow at 6:30 p.m. Indian time. And hopefully you'll join us on both the days as well for the rest of the conference. So thank you and good night all.